good afternoon everyone. Respected faculty and delegates, on behalf of Pediatric Allergy Immunology Unit, Department of Pediatrics, Advanced Pediatric Center, PGI Chandigarh, I welcome you all to this prestigious academic event, which is Global Initiative of Academic Networks, Gian. The theme of this academic program is long-term follow-up and cardiovascular management in pediatric medium vessel vasculitis, which is going to be held from March 22 to 26, 2025. Now for the inaugural session, with deep regards, may I invite Professor Etsuko Suda, our guest faculty, and Dr. Gurjaspreet Singh on stage. And I request Professor Sujit Singh and Professor Amit Rawat to kindly accompany Dr. Etsuko Suda and Dr. Gurjaspreet Singh to the stage. Dr. Etsuko Suda is a professor in the Department of Pediatric Cardiology, National Cerebral and Cardiovascular Center, Osaka, Japan. She is a world authority on the long-term follow-up of Kawasaki disease. I request Ms. Sanchi to kindly welcome Dr. Etsuko Suda with a bouquet of flowers. Dr. Gurjaspreet Singh is a professor in the Department of Chemistry at Punjab University, Chandigarh. He is the local coordinator of Gian, Ministry of Education, Government of India. He is a coordinator at the Energy Research Center, CRIKC. He is a Dean International and also an ambassador of the Association of Commonwealth Universities. May I request Ms. Vishali to kindly welcome Dr. Gurjaspreet Singh with a bouquet of flowers. May I now request Dr. Gurjaspreet Singh, a local Gyan coordinator, Punjab University, to kindly introduce the gathering about Gyan course.
A very good afternoon to Professor Etsuko Suda, Professor Sujit Singh, Professor Rakesh Plani, Professor Amit Rawat, and all the participants, faculty member of APC, and everyone present here. I welcome you all to the international workshop on long-term follow-up and cardiovascular management in pediatric medium vessel vasculitis, and event under Global Initiative of Academic Network Gian. Global Initiative of Academic Network Gian in higher education was launched in 2015. It is a program of Ministry of Education aimed at tapping the talent pool of scientists and entrepreneurs internationally to encourage their engagement with the Institute of Higher Education in India. Gian envisages to catalyze higher education institutions in country, and it includes all PGIs, IITs, IIMs, central universities, IISc Bangalore, ISERs, NITs, IIITs, subsequently covering good state university, where the spin-off is vast. Gian is an evolving scheme which includes participation of foreign faculty in institute as a visiting faculty or professor of practice to participate in delivering 5 or 10-day courses. The first course was conducted by Punjab University in year 2016. 25 courses have been conducted so far. Currently, 10 courses have been sanctioned for phase 4, that is for year 2024 to 25. Call for the phase 5 course shall be released shortly. Our motive is to engage more and more participants from various institutes and to accelerate the vigor of Gian. For further detail, you are most welcome to contact me. I wish you all a great learning experience with Professor Etsuko Suda. Thank you.
May I now request Professor Sujit Singh to kindly inaugurate the Gian course and introduce Professor Etsuko Suda.
Professor Etsuko Suda, Professor Gurjaspreet Singh, Professor Amit Rawat, ladies and friends. We are very fortunate to have been sanctioned this course under the global initiative of academic networks, and this is basically due to the efforts of Professor Gurjaspreet Singh, who has gone out of his way to help us in getting this course through. And this would be the third such course that has been sanctioned to our department. We are also very fortunate to have as eminent a personality as Professor Etsuko Suda to be the guest faculty for this course. And I don't think many universities or many institutions in the world would have the privilege of having Professor Suda for full 5 days. So this is, I think we are very, very fortunate to benefit from her expertise, from her experience under this initiative of the Ministry of Education. Professor Suda works in the Department of Pediatric Cardiology at the National Cerebral and Cardiovascular Center, popularly known as NCVC, in Osaka, Japan. The NCVC is a premier institute of Japan, and it conducts path-breaking research in neurology and cardiology. And publications from NCVC have changed the way diseases are managed, have changed the way patients are managed. So it is the #1 center in cardiovascular diseases in Japan, and the doctors who work there are really the top end of surgeons, the top end of cardiologists, the top end of neurologists and neurosurgeons who get to work at this institute. To give an example, Dr. Kitamura, who is the preeminent cardiac surgeon for Kawasaki disease, who started operating on children with Kawasaki disease in the 80s. And he was the first surgeon in the world to be able to do coronary artery bypass grafts in small children over arteries that were no bigger than 1 millimeter. How he did it using technology which was very primitive at that time, only he knows how he managed to do it. He's a real craftsman, and over the years he put the surgery of Kawasaki disease at a different pedestal. At the International Kawasaki Disease Symposia, I have heard American surgeons saying that yes, for this child, such and such thing can be done, but only Kitamura can do it. We can't. You know, such was his stature. And he had the privilege of working at NCVC, and he also was the director of the NCVC. Professor Suda is equally accomplished, equally well known, as can be, as is very obvious from the publications with which she has been associated. And her expertise lies in very long-term follow-up of children with Kawasaki disease and managing the complications associated with Kawasaki disease. She probably has more experience in managing children with Kawasaki disease than any other doctor in the world. Her follow-up data, her experience in managing complicated cases of Kawasaki disease is matchless, as can be gleaned from this set of publications. A survey of the 3-decade outcome for patients with giant aneurysms caused by Kawasaki disease, follow-up extending over 30 years. 25-year outcome of pediatric coronary artery bypass surgery for Kawasaki disease. They have done 25-year follow-up of a surgical operation which not many people can do, not many people in the world can do. Our association with Dr. Suda goes back over 10 years. It was in April 2015 that I was attending the meeting of the Asian Society for Pediatric Research. And this was held in Osaka. So I had a day free. So I requested Dr. Hirohisa Kato if he could arrange a meeting with Dr. Suda at the NCVC. And Dr. Kato was gracious enough to immediately arrange the meeting. And that is how I got to visit Dr. Suda and to visit the NCVC. I spent several hours at the NCVC, and Dr. Suda was very gracious to spare that much time, and she showed us several patients with Kawasaki disease, their follow-ups, some of them who had been operated. It was an eye-opener for me at that time. She showed some of her imaging studies. So this is a child with Kawasaki disease who's developed coronary artery calcifications, and the onset of Kawasaki disease was at 20 months, and the patient was aged 21 years, follow-up of more than 2 decades. The same patient showing the aneurysms over the left coronary artery. This is another patient who had developed aneurysms within the first few days of Kawasaki disease. And these are the follow-up films after 6 years and after 13 years. So this is the kind of follow-up that they have at the NCVC. This is the left coronary artery, again after 6 years and after 13 years. For me, all this was new at that time, because we had just started doing CT coronary angiography. We had started in 2013, and by 2015 we had done a few cases, but we were still not very sure of what we were doing and how we would go on to develop this investigation. But seeing her work, I realized that this is a way forward. Managing Kawasaki disease doesn't stop at the acute episode, because it is not a one-time disease of childhood. It leaves behind several sequelae, and not all of which are benign. Our next contact with Dr. Suda came in October 2017, when she very kindly agreed to come over to PGI Chandigarh as a visiting professor to the Department of Pediatrics, and she honored us by delivering the 22nd Dr. Gian Berry Memorial Oration. This was in October 2017, and this was based on her long-term follow-up of children with Kawasaki disease who had developed aneurysms. From Chandigarh, she went to Calcutta and she attended the 15th National Conference of the Pediatric Rheumatology Society, which was held in conjunction with the West Bengal Pediatric Rheumatology Society, and she delivered the first oration of the West Bengal Pediatric Rheumatology Society. So this is Dr. Suda after delivering the oration at Calcutta. In January 2018, Dr. Suda and Dr. Manful were invited to write a review article on imaging studies in Kawasaki disease. And this was a special issue of the International Journal of Rheumatic Diseases. This was a special issue on Kawasaki disease. And we had people from all over the world contributing to this issue. And this manuscript was jointly authored by Dr. Suda and Dr. Manful Singhal. Then we had the privilege of meeting her in June 2018 at the 12th International Kawasaki Disease Symposium, which was held at Yokohama. This was a very special symposium because this was the last symposium that was attended by Dr. Tomisaku Kawasaki. So he passed away in 2020. So this was the last symposium, and we had the privilege of meeting Dr. Suda again at this symposium. And after the meeting was over, she very kindly led us to an excursion to the Kamakura Shrine and the Shirigahama beach. And accompanying her was Dr. Atsuko Suzuki, who is the world's #1 expert on MR angiography in Kawasaki disease. So Dr. Suzuki and Dr. Suda, they spent an entire afternoon with us at this excursion. We got to meet her again in October 2023, and this was a meeting with Dr. Manful Singhal. Dr. Suda offered to arrange 2 weeks training for Dr. Manful Singhal at the NCVC Osaka. And Dr. Manful and Dr. Suda had several sessions together. They exchanged notes, and Dr. Manful came back convinced that we need to further develop our imaging studies. And this was also the time when we started doing MR angiography in children with Kawasaki disease. So this is Dr. Manful Singhal with Dr. Kitamura. Dr. Kitamura and Dr. Suda. Dr. Kitamura, of course, has retired by this time, but he again was very kind enough to come over to meet Dr. Manful. Dr. Manful spent another 2 weeks at the Mie University Hospital training with Dr. Yoshihide Metani, and this was yet another aspect of imaging of children with Kawasaki disease that he worked on. I'll end my talk by paying our tributes to the 2 legends on Kawasaki disease from Japan, Dr. Tomisaku Kawasaki himself and Dr. Hirohi Sakato. And this auditorium and this stage have had the privilege of hosting both of them here right in this corner in October 2005. In 2008, I got an opportunity to visit Dr. Kawasaki at the Kawasaki Disease Research Center in Tokyo, and I requested him if he could take me to the Japanese Red Cross Medical Center, where he had first described this condition. And he agreed immediately, and both of us went by the Tokyo Metro to the Japanese Red Cross Medical Center, and this is Dr. Kawasaki standing in front of the hospital building. This is in his office at the Japanese Kawasaki Disease Research Center, and with Dr. Kawasaki are his long-term associates, Mrs. Noriko Sato, who worked with Dr. Kawasaki for more than 40 years, Ms. Yasuko Fujinami, and the person in front is Mr. Mitsuru Asae, whose son had Kawasaki disease and who unfortunately succumbed to this, and he formed the Japanese Parent Society for Kawasaki disease. And on 2 occasions that I visited Dr. Kawasaki at this center, on both occasions I also had the privilege of meeting Mr. Asae. Unfortunately, he is now no longer with us. This is a very special slide where Dr. Kawasaki is being wished a happy birthday on February 7, and the person who is wishing him happy birthday is Mr. Shunichi Yamazo. Shunichi was the first child with Kawasaki disease whom Dr. Kawasaki had diagnosed in 1962. So he kept contact with Dr. Kawasaki till the day he retired. So such was the follow-up of Dr. Kawasaki. So as I said, this was the last Kawasaki disease symposium attended by Dr. Kawasaki. These symposia are held every 3 years. They are not held annually. And this was our last photograph with Dr. Kawasaki, our senior residents who were attending this meeting along with Dr. Kawasaki. He was on a wheelchair at this symposium, but he attended all 3 days of the symposium, morning till evening. He was there throughout, both he and his wife, Dr. Riko Kawasaki. And this is the speech that he gave. So this is Dr. Kawasaki, who did not work in an academic institute. He worked in a non-teaching hospital. He had the courage, he had the conviction to stick to his diagnosis. He convinced all the professors of Japan that what he was discussing was indeed something new, even when virtually all of them opposed the diagnosis. So he went on to describe a condition which now is the commonest cause of acquired heart disease in children, not only in the developed world, but also in the developing world. So Dr. Kawasaki passed away on June 5, 2020, and this is his daughter and his son paying their respects at his resting place, which is not very far from the Japanese Red Cross Medical Center in Tokyo. As I said earlier, we were privileged enough to have two legends with us in October 2005, the other legend being none other than Dr. Hirohisa Kato. Dr. Kato was a big friend of Dr. Kawasaki, and he was the first cardiologist to actually do coronary angiographies to demonstrate the aneurysms, coronary aneurysms. And he did it in 70s. You can imagine what kind of technology must have been available there. He had to improvise many things, but he was able to demonstrate these aneurysms for the first time in the world at that time. So he had very kindly accompanied Dr. Kawasaki in October 2005 when both of us were here. So this is again Dr. Kato giving his talk. He is well known for his lifelong work on Kawasaki disease, but his preeminent publication, which has virtually thousands of citations, is the long-term consequences of Kawasaki disease, a follow-up study of 594 patients, which is still being cited after more than 28 years of its publication. This was the preeminent publication which really showed the world what Dr. Kato's work was all about. So Dr. Kato again used to be there at all international symposia. He was there at Yokohama as well, but unfortunately he breathed his last just a few days ago on March 14, 2025. And as a mark of respect to Dr. Kato, may I request everyone in the audience to please rise in their seats and observe a minute's silence. Thank you. So Dr. Kawasaki and Dr. Kato changed the perspective of this disease, and I think this disease now has attracted the attention of all pediatricians, many cardiologists, many internists in our country, and over the next 5 days, we would have Dr. Suda with us telling us the impact that this disease has on children with Kawasaki disease and why this should never be considered a benign one-time febrile illness of childhood. Thank you very much.
It's an honor to welcome you all, and now, without any further delay, we may please proceed to the next session. And for this session, may I request Professor Sujit Singh sir to please chair the session. Then, the talk would be given by Dr. Rakesh Pilania, and his talk would be on Kawasaki disease, why early diagnosis. Sorry. I'm so sorry. For this session, may I request Professor Atsuko Suda to please deliver his lecture, her lecture.
So next slide. This is laser.
Mr. Chairman and ladies and gentlemen, I appreciate the opportunity to speak on this subject at this section. The title is Epidemiology of Cardiovascular Kawasaki Disease, the Japan Experience. First off is history of KD survey in Japan. What do we know about KD? The cause of remains unknown. Acute KD vasculitis, hypercytopenia involving medium-sized vessels. The effective peak age in acute febrile disease of children is second only in extensive individuals. The occurrence of the disease is greatly dependent on abnormal immunologic responses and hereditary factors. The presentation of acute KD varies significantly referred to a typical KD and incomplete KD. Further, it seems this vasculitis manifests differently depending on patient age. Patients less than 3 months of age tend to have few symptoms. On the other hand, severe myocarditis can predominate in patients with more than 4 years old. Abdominal pain and arthralgia often occur in school-aged patients. In short, KD remains a mysterious disease and its diagnosis is challenging. Dr. Kawasaki passed away on June 5, 2020 at the age of 95 years. Dr. Kawasaki believes facing medicine. Medical science is rigorous. Medical care is compassionate. KD is very interesting and mysterious disease. KD was reported by Dr. Kawasaki in Japan 50 years ago. So when was KD recognized? Dr. Kawasaki believed he saw the first KD case in 1961. In Japan, it is considered that KD first occurred about 1950. With Japan experienced the end of the Second World War in 1945 and was followed by rapid economic development and dramatic social change in Japan. KD appeared during these big major environmental change. Professor Singh and Dr. Kawasaki published the journey over 50 years. Dr. Shigemichi, Director of the Department of Epidemiology, National Institute of Public Health, decided to start a nationwide epidemiological survey of KD. The first national KD survey at 1970 in Japan indicated coronary artery involvement and cardiac death 1.4%. The age range ranged from 3 months to 2 years 7 months, with a median of 6 months in the acute phase of Kawasaki disease. The interval from the onset of acute KD to death was from 17 to 54 days, with a median of 26 days. Sudden death occurred in 7 patients, and heart failure was 2 patients. In autopsy, coronary arteries, coronary aneurysms, and acute myocardial infarction due to thrombotic occlusion of coronary aneurysms were found. Since 1970, nationwide epidemiologic surveys of KD have been conducted in Japan every 2 years. The surveys reported the annual number of Japanese patients with KD, the prevalence of CARS and coronary artery lesion and valvular lesion. Dr. Nakamura and Ms. Yashiro worked in nationwide epidemiological survey from 1971 to 2022. They published many important papers. A questionnaire form was sent to all hospitals with a pediatric department 100 or more beds. The response rate has continued to be over 70% in recent years. The yearly number of reported patients by sex, 3 nationwide epidemic in Japan. The annual number of patients has increased gradually. However, the number of patients decreased by about 2,000 from the previous year due to pandemic COVID-19 in 2020. The number of male was higher than that of female. The sex ratio was 1.4. The distribution of age groups was shown. We calculate the age as of the January 1st, 2023 of the 445,000 people currently registered. The seasonal pattern is specific. The largest number of patients is in January, small peaks in summer. This graph shows the age-specific incidence rate by sex. The age-specific incidence rate was the highest for infants aged 9 to 11 months. Age-specific incidence rate also suggests the presence of infectious agents. The rate is quite low among infants younger under 6 months, perhaps because of passive natural immunity from mothers. This graph shows percentage of patients with cardiac impairment by sex and age. It was more common in males than in females, and common in infancy. A slightly higher tendency is also observed for older children, aged 5 and older. Kawasaki disease was reported in the worldwide. The incidence rate of Kawasaki disease, Northeast Asian, are almost 20 times those of white. Recurrent case was found in 3%. Civilian cases were in 2%, and parent-child cases was in approximately 1%. Incidence rate differ by race. Incidence is highest among Japanese, followed by Asian, African American, and white. In Japan, an epidemiologic national survey has been performed every 2 years. In the most recent survey, the total number was about 21,000. About 1/5 were regarded as incomplete KD. 96% of patients received IVIG therapy, and 5% of patients steroids with IVIG therapy. 17% of patients treated with IVIG failed to respond. The number of each additional therapy for the initial IVIG resistance is shown. About 20% of KD patients have persistent or recurrent fever more than 36 hours after the end of initial IVIG infusion. There are delay of the diagnosis and incomplete KD. In our 1981 study, coronary artery dilatation occurred at the 9th illness day, and the coronary aneurysm appeared on the 11th illness days, while coronary aneurysm appeared up to the 17th of illness. We must know that the time of coronary artery formation is later than time of alleviation fever. Proportion of the patient with CAA in acute phase was 8.1%, and 1 month after the onset of KD was 2.5%. Giant aneurysm exceeding 8 mm were only 0.1%. Changes of incidence of coronary artery lesion were shown. Coronary artery lesion developed in 2.3%. The changes of relation between total IVID, 2 gram per kilogram, and incidence of giant coronary artery lesion were shown. The incidence of coronary artery lesion had decreased with the increase of use of IVIG. The changes of relation between total IVIG and incidence of giant aneurysm were shown. The incidence of giant aneurysm had decreased with increase of the use of IVIG. The changes of treatment for IVIG resistance were shown. The incidence of giant aneurysm had decreased with increment in aggressive treatment. The number and incidence of deaths in national survey are shown in this slide. The mortality rate for KD was 0.4% in 1970s and 1980s. It decreased less than 0.1% during 1990s. The most causes of this before 1985 was myocardial infarction. However, the percentage of myocardial infarction was decreased from 1990s. Second talk is valvular lesions caused by KD. As you know, acute KD involves cardiac lesion especially, although their prevalence of following is very low. Severe cases of endocarditis, myocarditis, and pericarditis are sometimes encountered rather than coronary arteritis. Endocarditis leading to mitral regurgitation especially occurs in patients under 6 months. Myocarditis was unconsciousness in the early days of the acute phase occur in patients more than 4 years old. Pericarditis is found in both acute and late phase. Cardiac tamponade is a rare event. The percentage of each cardiac sequelae at 1 month after the onset of KD was shown in this slide. More precisely, cardiovascular sequence were coronary dilatation in 1.3%, coronary aneurysm 0.64%, valvular lesion in 0.36%, giant coronary aneurysm 0.13%, coronary stenosis 0.02%, and myocardial infarction in 0.02%. Their sequelae, except for valvular lesion, occurred more often in boys. In addition, the complication rate of giant aneurysm coronary aneurysm and coronary dilatation were most prevalent in atypical KD. Valvulitis is considered to occur with pancreatitis caused by acute hypercytopenia. Fujiwara shows that prevalence of the pathologic finding of mitral valvulitis, tricuspid valvulitis, and aortic valvulitis was 88%, 63%, and 100% respectively. Although valvular regurgitation in patients after KD has been reported previously, there have been no reports of valvular stenosis. It is known that idiopathic RMCT of new syndrome also occurs in small infants without a history of KD. In Japan, RMCT, which can occur suddenly in the early course of acute Kawasaki disease, has been found since the middle of the 1990s, and it also has been complicated by acute heart failure. RMCT often require surgical repair, such as mitral valvuloplasty or mitral valve replacement in rescued patient. The prevalence of RMCT was considered to be at least about 1 in 20,000 in present study, and its occurrence was rare. RMCT leading to severe MR is a critical complication in small infants, especially within 6 months. 8-month-old girl, infant had acute KD. On the 5th day and 11th day, immediately after IVIG was administered, fever was alleviated. There were no coronary aneurysms. On the 19th day, a systolic heart murmur was detected at her regular outpatient clinic visit. Slight to moderate mitral regurgitation owing to ruptured shoulder tendinitis of anterior middle leaflet of the mitral valve was detected by two-dimensional echocardiography. A 5-month-old female infant with mitral regurgitation was referred to our hospital. Acute typical Kawasaki disease was diagnosed at 3 months of age. No abnormal findings were observed when she was discharged on the 14th day. However, she became febrile with a cough and irritability behavior on 31st day after the onset of acute KD. On the 35th day of illness, she was admitted to nearby hospital with decreased activity. On admission, the systolic heart murmur and hepatomegaly were confirmed. Despite diuretics and catecholamine were administered, her heart failure progressed. Pulmonary edema was detected on chest X-ray and oxygen inhalation was needed. She was transferred to our hospital on the 57th day of illness. Severe mitral regurgitation owing to ruptured shoulder tendinitis of posterolateral leaflet of mitral valve was diagnosed by two-dimensional echocardiography. Severe mitral regurgitation was detected in the left ventricular. She was maintained on angiotensin-converting enzyme inhibitor, plasmin, and spironolactone in the outpatient clinic. At 7 years old, she underwent mitral valve annuloplasty with resection of the posterolateral leaflet. The left ventricular end diastolic dimension by 2DE decreased to normal left ventricular dimension, and her mitral regurgitation improved from severe to trivial. No medication were required post-surgery. She has been doing well. Therefore, we clarified the characteristic of valvular lesion after KD with the Japanese nationwide survey. In the nationwide Japanese KD survey between 2007 and 2016, 137,000 patients were reported. In those surveys, numbers of patients with acute valvular lesion and those with valvular sequelae, 1.4% and 0.35% respectively. In the surveys, acute valvular lesion were defined as those that developed within 1 month after the onset of KD, and valvular sequelae were those that persist beyond 1 month after the onset. Therefore, details of each valvular lesion in 479 patients with valvular sequelae were further investigated by questionnaire. The questionnaire was returned by mail from institution 78%, and the total number of patients with valvular sequelae due to Kawasaki disease was 290. There are 155 male, 53%. The median age at the age of KD was 29 months. The grade of each valvular regurgitation was shown. The number of patients, each type valvular regurgitation during each stage was as follows. Acute stage, mitral valve 72%, tricuspid valve 40%, aortic valve and pulmonary valve 15%. The age at onset of Kawasaki disease, significantly younger in patients in moderate MR and severe MR than in the patient with no and mild MR. RMCT was found in 6 patients with valvular sequelae. Number of patients with each type valvular regurgitation, to age at RMCT, RMCT was found 6 patients. There were 3 male and 3 female patients. 2 of 6 patients had incomplete Kawasaki disease. The age at onset of RMCT ranged from 5 to 10 months with a median of 7 months. The age at onset of KD, 3 to 5 months, and the interval from the onset of Kawasaki disease to RMCT, 5 to 10 months. At 1 month, 1 year, Kawasaki disease. RMCT was found 6 patients. This slide shows the degree of TR is the age at patient in TR Oh, sorry. Sorry. The degree of MR improved significantly more at 1 month after KD than during acute phase. The degree of AR improved significantly more at 1 year after KD than during the acute phase at 1 month. However, the AR in the 3 patients with moderate AR persisted in late period, although most mild AR improved. The degree of TR improved significantly more at 1 year after KD than during the acute phase and 1 month after KD. There are no difference among the 3 groups in the prevalence and degree of TR. There were no difference in prevalence and severity of MR by sex. However, there was significant difference in the severity of MR in the IVIG responder and IVIG resistant groups during the active phase. The MR was significantly more severe in the IVIG resistance group than the IVIG responder. Furthermore, there was significant difference in the severity of MR between the patient with CARS and those without CARS during the acute and late phase, respectively. Summary, subclinical valvulitis with pancreatitis due to acute KD can easily affect the function of the mitral valve. Most of the valve regurgitation, including MR, was mild and disappeared in late period. The severity of MR related to the response to IVIG. RMCP in small infants rarely occurs less than 4 months after KD. Thank you for attention. I was invited in Chandigarh and the 15th National Conference of Pediatric Rheumatology Society in Kolkata. I was happy to meet you and discuss in conference. Everything was young. I have had a lot of memories since that time. I'm happy to be you again, Chandigarh. I'm pleased to invite me. I greatly appreciate you. A lot of good memories. I'm happy to meet you again in Chandigarh. Thank you.
Thank you, Dr. Suda. If there are any questions, I think we can take a couple of questions. So what she has basically introduced us to is the fact that KD is a pancarditis. So it's not only coronary involvement. We are well aware of the myocarditis, but the endocarditis component of KD, I think, still is not being given as much attention as it should be. So, for instance, at our own center, we have never paid much attention to the valvular regurgitations. We have not looked at the echoes for valvular regurgitation. But maybe other centers have a different experience. Devdata?
Possibly due to partially drawn kidney, but it
My worry is somewhat different. If you have a febrile illness and you are left with some regurgitant lesions, my worry is that many of these children may be misdiagnosed as rheumatic fever and started on penicillin. And I'm sure this must have happened in the years gone by. So, since Kawasaki disease is so common, as pediatricians we need to be aware that valvular involvement in Kawasaki is not uncommon. So I think this is the larger message that we can get from this talk. Any other questions? Okay, if not, thank you, Dr. Suda. We go on to the second talk in this session. Dr. Shankar Prinja is not with us today, but he will join us later during the course. And in his place, we have Dr. Rakesh Kalani.
Thank you, sir, and thank you, madam, for giving us such a lucid lecture. And we have been introduced with the term endocarditis involvement, which is very significant. And in this talk, I will be covering the why we are learning about Kawasaki disease for young ones. What is Kawasaki disease? Why we are doing this Gian course, or why we are learning about Kawasaki disease, that why diagnosis and treatment of this disease is essential. So the basics of Kawasaki disease is that Kawasaki disease is a medium vessel vasculitis, and it has a special predilection for coronary arteries, and it's a disease of young children, children below 5, but no age is immune for this disease, and children, older children and even adults can also be affected rarely. But the most important part is that despite 6 decades, we have a clinical diagnosis of this disease, and we don't have anything which is a pathognomonic laboratory test for this disease. So the diagnosis rests on the clinical signs, and we all aware about this classical clinical signs like fever for at least 5 days and presence of 4 out of the following 5 conditions like conjunctival injections, polymorphous rash, cervical lymphadenopathy, mucosal changes, and acral skin changes, and the illness not explained by other known diseases. But the important part is that this is a clinical epidemiological case definition. This is not a diagnostic criteria. So we have to know that we should not be behind the fitting the criteria for the diagnosis of this disease. And it has been highlighted, and it should be highlighted more and more. It is the most common childhood vasculitis, and it is the most common cause of acquired heart disease in children. And it's nowadays we call it's a worldwide most common cause of acquired heart disease in children. We don't see much of acute rheumatic fever. Whatever we are seeing is the ravages of acute rheumatic fever, that is rheumatic heart disease, which has been there previously. So as have been highlighted by Dr. Suda also, that the diagnosis of KD depends, it also depends that in which age you are seeing. And in infants, there is the diagnosis of KD is almost always difficult, and it's almost always incomplete. We don't see much of complete KD in this age group. Almost, I would say 80 to 90% of infants, specifically less than 6 months, would not fit the criteria. And at this age, it is important that almost 50% of children, like infants, would develop coronary artery abnormalities. So this is a significant component that we should know that when to suspect Kawasaki disease. And other extreme is that KD can sometimes present in older children and adults. Similarly, the delays in diagnosis would be there again, and because of delays in diagnosis, again the chances of development of coronary artery abnormalities would be significantly high. So the KD is not a one disease, and we have an expanded spectrum of disease. When like it present in a differently in infants, it can present differently in older children and adults, but sometimes it can have a atypical manifestations. Whenever there are any other manifestations which are not described in the principal clinical features, these features like neurological features, renal manifestations, or any other abdominal manifestations, like these manifestations are there, then these are atypical Kawasaki disease. And few children, so like 1 to 2% of children can have a very severe disease like development of macrophage activation syndrome. So we have to identify these patients in a spectrum of Kawasaki disease, because this is a precision medicine in a Kawasaki disease, that we have to identify the different group, subgroup, and we have to treat differently. We have to identify this patient differently. So the macrophage activation syndrome can be seen in around 1 to 2% of children with KD, and it's almost 50% of children who had macrophage activation syndrome can develop coronary artery abnormalities or cardiovascular complications. So such a need for identifications of macrophage activation syndrome. So whenever we are dealing with the severe or refractory diseases of in Kawasaki disease, we should suspect the macrophage activation syndrome, and we should work up these children for that. So this is a similar child which we managed this child in a ICU setting, and this child remained almost a month in ICU and required several of therapies, developing the significant myocardial collapse, and ejection fraction was less than 20% and required the several of therapies, and finally and the pro BNPs were more than 1 lakh. So this suggests that this disease can come to the emergency settings and ICU settings also. That is known as a KD shock syndrome. So whenever we are dealing with the children in emergency setup, children with acute cardiovascular collapse or shock, where we are thinking most of the time septic shock, but blood cultures are negative, think about the Kawasaki disease as a differential. So missing a diagnosis of KD can have serious consequences, and something like this was a 17-month-old girl who came with a fever for 3 weeks, and there was excessive irritability and some generalized erythematous rash was there. But what happened was that there was a urine examination and which showed pyuria. And in infant, whenever you are having a pyuria, you would think a urinary tract infections. But the sterile pyuria, the most common cause is Kawasaki disease. And what more thing happened is that this child went on to have several investigations related to the pyuria, multiple urine cultures, ultrasound KUB, CT head, CT chest and abdomen, because fever was persistent despite all the antimicrobial. But what we were missing was that this is a child with Kawasaki disease, and this baby had developed several giant aneurysms, and further CT also confirmed. So the incomplete nature of this disease highlights that we have to think a differential in any prolonged fever, more than 5 days of fever in a children, think this differential. If you will think, then only you will work up these children. So the pathogenesis of KD is still an enigma, but it is evolving, and it's disease which has several risk factors which has been highlighted, but the most proposed theory is that this is a disease which happens in a genetically predisposed individual with some unidentified, probably some infectious agent which is causing the pathogenesis. So you will listen many talks on this next. So the evidence in favor of genetic basis is that it's a skewed epidemiology. We have seen that the incidence of Kawasaki disease in Japan is highest. The recent paper in 2025, the incidence of Kawasaki disease has reached to more than 400 per 100,000 children in Japan, which is a very high. So something like that, they report 15,000 children per year with a Kawasaki disease in Japan. So occurrence in sibling and children with younger children suggests that there is some infectious etiology which is causing the molecular mimicry and in a genetically predisposed individual. So the cardiovascular assessment in KD is an important component, and we need to learn about the coronary artery abnormalities, KD myocarditis, KD shock syndrome, and if you don't treat that, up to quarter of patients can develop a cardiovascular complications, and in less than 5% of children still can develop who receive the treatment on time. So Professor Nazib Dada has first time described this as that it's not just coronary arteritis, Kawasaki disease is a myocarditis too. And we ignore this entity, something like that, because the myocarditis is an integral component of Kawasaki disease. It's there in almost always in all patients, but the symptomatic myocarditis will seen in almost 5 to 10%, something they can present with a cardiovascular collapse or hemodynamic instability. So while the coronary artery abnormalities develop in 15 to 20%, myocarditis is almost universal, and sometimes they can present to the pediatric ICUs or emergencies presenting like a KD shock syndrome. And the cardiovascular involvement has been, as highlighted by Professor Suda also, that it's not just limited to the coronary artery abnormalities. We can have several other things like myocardial dysfunctions, valvular regurgitation, aortic root abnormalities, and pericardial abnormalities. So the coronary artery abnormalities in our cohort also, the prevalence of coronary artery abnormalities has significantly risen, possibly because of several reasons, because of using the G-score system and the more frequent echocardiography which we can do in-house echocardiography, and also we are nowadays we are doing CT coronary angiography in all patients who are having a very severe disease or wherever we are having any suspicion of coronary artery abnormalities. So CT coronary angiography is an imaging paradigm which Professor Manful Singhal will be talking in his talks, and the therapeutic regime of Kawasaki disease has evolved over the years, and what in 1967 was when we didn't had any treatment, something like that, it started with some erythromycin and aspirin. Now we are reaching with standard of care as IVIG with treatment intensification with several other things, and IVIG treatment of IVIG resistant KD. So by this time you know that why should KD be diagnosed and treated, because KD is not a benign disease of one childhood, and it can leave behind several sequelae, and if you don't treat, almost quarter of patients can develop coronary artery abnormalities, and these are the long-term effects of this disease. So patients with coronary artery abnormalities as a result of childhood KD remain at risk of several cardiac sequelae throughout their life. So just I will conclude that the KD is the commonest cause of acquired heart disease in children, and it's not a one-time disease of childhood, and it can leave behind several sequelae like coronary sequelae, myocardial sequelae, systemic sequelae, and adult coronary artery disease. So I will conclude by something which quoted by Professor Nazib Dada is that Kawasaki disease does in a 5 days what atherosclerosis does over 5 decades. Thank you.
Thank you, Rakesh. This talk is now open for comments and questions.
I have a question about since the initial manifestation could mimic any of the viral examples, does the delay required time the patient is referred and diagnosed, does the delay treatment in impactful outcome of these patients? Does it take a few days or a few months by the time patient comes to the or
Thank you for the question. So basically, this is the most important component because the diagnosis here is clinical. And in this age group, we have several other differentials like viral exanthems and more so in a tropical country like us. So, nowadays probably in last 1 decade, there is an increased ascertainment of this disease, and the pediatricians are more tuned to the diagnosis of this disease. And yes, definitely we have to treat this disease within 10 days. If we have to diagnose and treat with this disease within 10 days, because the IVIG should be given as soon as possible. If there is a delay after 10 days or even after 10 days, the development of coronary artery abnormalities, chances of development of CA is very significant. So this factor is a very important, but we have to take into the context because, and more important is that the symptoms appears in a temporal sequence also. Sometimes fever will be there, and after fever there will be development of rash. By the time the child will reaching you, something like conjunctival injection may or may not present. So we have to take all the clinical features and we have to ask in history. mother is a very keen observer and they will tell that there was red eyes, or this is a very important component, that whenever a young child coming with fever, the differential of Kawasaki disease should be there with the clinician. If there is a differential, people, like, you have to ask or you have to see these clinical features.
I think in the hall we have experts from all over the country, and they are all very well versed with picking up TB, but I think I'll still emphasize the fact that when a child comes with fever and the fever crosses day 4, day 5, the thing you must never do is start antibiotics without a reasonable diagnosis. Antibiotics will really mess up that situation. So what happens usually is you are given a course of broad spectrum antimicrobials, fever persists, the parents go to another pediatrician, they change the antimicrobial, fever persists, they go to yet another pediatrician, they go on to intravenous antimicrobial. A child who has had more than one course of antimicrobial and fever is persisting, I think our threshold for TB should be really low. Just this morning, we had a patient who Dr. Suda saw. This was a doctor's child. The baby developed fever, 7-month-old developed fever, given a series of antimicrobials. The treating unit thought of Kawasaki disease, but did not treat, saying that the echo is normal. Now, echo is not essential for diagnosing Kawasaki disease. In fact, quite often it leads you astray. So the question that you have asked, I think, is very, very important. We really have to have a very low threshold for Kawasaki disease. We have to remember that antimicrobials are not antibiotics. Children do not need antimicrobials for most fevers. And if there is reason to start an antimicrobial, we must have some diagnosis. So, Dr. Pratap?
How easy to or difficult to make diagnosis of atypical TB, and what percent of children present with atypical manifestations, and you have the cohort of only 18-20.
So question is that like now, how difficult to make a diagnosis of KD in atypical manifestations. So it's almost always not easy. So because the atypical KD will not present to you basically as a rheumatologist or like something like that. It will present to several specialties. Sometimes, like we have seen, it will come to the neurologist with something like a seizure or something like a facial nerve palsy, which I can still remember an adult, 30-year-old adult who came with a facial nerve palsy, and she had all the features of Kawasaki disease. But what was odd was age, and then it was a facial palsy, and to convince that it's a Kawasaki disease, it take a very much time. But there are several other manifestations like renal manifestation, like acute kidney injury. Sometimes it can be just a urinary abnormality like sterile pyorrhea, which we see, and something like other atypical manifestation which we see. So it's easy to make a diagnosis of atypical KD when you are having a features of all complete KD. But if there are only a fever and their atypical manifestation, is almost always a difficult thing, and diagnosis of KD will evolve sometimes, and we have to treat KD rather than waiting for the fulfilling the criteria at that time. We don't have a specific data for atypical Kawasaki disease, how many patients we have not looked into this, but possibly we can see that.
Okay. If there are no more questions, I thank Dr. Rakesh for this talk.
Good afternoon, everyone. Professor Sujit Singh and Professor Amit Rawat to please chair the session.
So we now go on to the Professor Lata Kumar lecture in Pediatric Immunology. Professor Lata Kumar was my teacher, my mentor, and she started the specialty of pediatric allergy immunology. She was the first one to start diagnosing these conditions, not only at PGI, but perhaps the first one to do so anywhere in India. She was thinking of immunological disorders, she was thinking of vasculitic disorders in the 80s when these conditions were virtually unknown. And whenever you diagnose these conditions, the common refrain was, these conditions do not occur in India. But she was the real pioneer who was trained at Denver in US and then came back to India and joined this department and went on to establish the specialty unit of pediatric allergy immunology, the only one of its kind in India. She headed this department with great distinction and she superannuated in the year 2002. She passed away in February 2020, just a few weeks before the pandemic started. So to deliver the Professor Lata Kumar lecture, we have Professor Etsuko Suda, and she will be talking on her pet subject and on which she is a world authority, that is the long-term management of giant coronary aneurysms in Kawasaki disease. There is no one more experienced, more distinguished than Professor Suda to talk on what happens to giant coronary aneurysms in Kawasaki disease. Professor Suda, please.
Mr. Chairman, ladies and gentlemen, I appreciate to speak at this section. I am honored. The title is Giant Coronary Artery Aneurysm, Long-Term Fate. First talk is characteristic and changes of coronary aneurysm. In our 1981 study, coronary artery dilatation occurred in the 9th illness days, and coronary aneurysm appeared on the 11th illness days, while coronary aneurysm appeared up to the 17th of the illness. We must know that the time of coronary artery formation is later than the time of alleviation of fever. We can see clinical course of a 6-year-old boy seen 1996, the initial IVIG resistance. He had very severe inflammation. CRP exceeded 30 milligrams per deciliter, and fever persisted for 11 years. We can see his serial echocardiography of right coronary artery are shown in enlarged progressively. Coronary artery was dilating until achieved giant status, CAA, at 20 stage illness. Further, serial echocardiogram of the left coronary artery are shown with dilatation of left anterior descending artery. This slide shows his coronary angiogram at 28 illness days. He had bilateral giant coronary aneurysms. This slide shows a patient with a giant aneurysm. Severe localized stenosis of the LAD was detected 7 years after KD. In same patient, the diameter of CAA was decreased 7 years after the onset of KD. He is a 16-year-old male. Coronary angiogram is shown. Coronary angiogram at 2 months after KD are also shown. He has been asymptomatic. He has taken warfarin and aspirin. Most giant aneurysms more than 8 mm persist many years after the onset of KD and are likely to evolve into stenotic lesions. On the other hand, regression of moderate-sized coronary aneurysm is quite frequent. In the left, showing the finding of 2DE and CAD in 1 month after the acute phase. On the right, those in 1 year after the onset are shown. In 1 year after KD, small aneurysms are detected by 2DE. On the other hand, it's almost normal coronary artery, although there is an irregularity of coronary artery wall. There is a slight discrepancy in the regressed aneurysm between 2DE and CAG. We can see outside of coronary artery by 2DE and the inside of vessel CAG. These pictures are left coronary arteries of the same patient. 1 year after KD, slightly dilated coronary artery is detected by 2DE and CAG. The remodeling of coronary aneurysms caused by KD is very interesting. Usually, most small and moderate-sized coronary aneurysms regressed within 1 year after the onset of KD. We see a case presentation. An 11-year-old male had KD at the age of 9 years. In the left, CAG 2 months after the onset of KD. A giant aneurysm of the left coronary artery is shown. In addition, wall thickening is detectable in the aneurysm DSCT in the right. In regressed CAA and persist CAA, intimal thickening was detected. Here is another example patient with localized stenosis due to severe intimal thickening 2 years after the onset of KD. Next, we can see localized stenosis in the left CAG, giant aneurysm in the LLD, and small aneurysm in the bifurcation of the LCA and left circumflex. Localized stenosis occurred just proximal portion of aneurysm of the LAD. Further, in this patient, localized stenosis has gradually progressed over more than 20 years. Furthermore, in this patient, localized stenosis has gradually progressed over more than 20 years. At the age of 40 years, severe calcification was detected in both giant aneurysm by CT imaging. Localized stenosis occurred with coronary artery calcification many years after the onset of KD. Calcified aneurysm in the proximal portion is characteristic of coronary artery lesion caused by KD. This patient had acute KD at the age of 3 months old. These pictures are coronary angiogram 2 months and 1 year after the acute KD. They are giant aneurysms. 5 years after acute KD, the diameter of both giant aneurysms was decreased. Nine years after acute KD, the aneurysm in the right coronary, right coronary artery was occluded. On the other hand, collateral artery from left circumflex to the right coronary artery developed. This patient, in the same patient, coronary angiogram of the RCA was shown. In this patient, localized stenosis progressed over many years. If myocardial ischemia developed, we planned an intervention for localized stenosis. However, asymptomatic occlusion was detected at 27-year-old. Collateral artery from LAD to LCX, LAD and LCX to RCA were developed. This slide shows coronary angiogram 2 months and 1 year after the onset. After 14 years, CT angiogram indicated calcification in the proximal portion of the LAD. Myocardial ischemia was detected in technetium myocardial perfusion imaging. Coronary angiogram showed severe localized stenosis of the LAD. Thrombus in coronary aneurysm of the left coronary artery was detected by two-dimensional echocardiography. A coronary angiogram showed an occluded left circumflex. Warfarin was added to the aspirin C was receiving. The cause of acute coronary syndrome by atherosclerosis in adult in plaque rupture. In contrast, acute myocardial infarction in Kawasaki disease is caused by coronary artery occlusion due to thrombus. This slide shows the interval from the onset of acute KD to initial myocardial infarction. Half of patients had had myocardial infarction within 6 months. It is said that thrombus formation occurs when 3 factors of ill health exist. Acute myocardial infarction after KD in most patients is caused by sudden coronary occlusion. Due to thrombus in the giant aneurysm, triggered by Wilfield's three factors for thrombus. First, endothelial dysfunction. The injured coronary artery wall due to severe acute vasculitis. Second, turbulence or stress within giant aneurysm. And third, hypercoagulability due to abnormalities of blood coagulation factors after KD vasculitis. The three factors manifested in the first year after KD. Acute myocardial infarction after KD in most patients is caused sudden coronary occlusion due to thrombus in the giant aneurysm. This patient had an inferior myocardial infarction 1 year after the onset of KD. The right coronary artery was occluded. After 4 years, segmental stenosis was detected. Segmental stenosis was often found in recanalization after asymptomatic occlusion. Furthermore, it is suspected that segmental stenosis results from coagulation and fibrinosis in giant aneurysm. Segmental stenosis was often found in segmental stenosis is characteristic of coronary artery lesion caused by KD. It's suspected that they occur in children within a few years after acute KD. This slide shows localized stenosis detected 18 years after KD, after regression of moderate-sized CAA. Localized stenosis can occur many years after regression of coronary aneurysm. Furthermore, acute coronary syndrome can occur in adult patients with regression of large aneurysm. Coronary artery lesion caused by KD is shown. In stenotic region, there were localized stenosis, segmental stenosis, and occlusion. Aneurysms are often found in branching site. In summary, first, giant aneurysm occurs the proximal portion of the major coronary arteries. Second, thrombotic occlusion and segmental stenosis typify the first year of acute KD. Third, progressive coronary wall thickening with calcification years and years later. Fourth, asymptomatic occlusion due to well-developed collateral arteries. There are morphologic changes of coronary arteries depends on degree of injury sustained by the coronary artery wall in the acute phase vasculitis phase. Second talk is outcome in patients with giant coronary aneurysm. The study involved analysis of 60 patients who had had previous myocardial infarction. The distribution of interval from onset of acute KD to initial myocardial infarction is shown. The median was 7 months after acute KD. The 30-year survival rate in this study was 63%. 15 deaths occurred. Sudden unexpected deaths in late period occurred in 6 patients. Survival rate are shown and depending on successful reperfusion. This difference is significant. In the next slide, The survival rate is shown depending on their left ventricular ejection fraction, post-myocardial infarction. The survival rate for the low LVEF group was low. Ventricular tachycardia free rate after myocardial infarction is shown in this slide. It would decrease 10 years after myocardial infarction. In this slide, the relationship of ventricular tachycardia free rate to the finding of larger isotope myocardial perfusion imaging are shown. The ventricular tachycardia free rate was low in the non-viability group. In this group, sudden unexpected death in the late period occurred. In summary, the outcome in patients after previous MI was also determined by the LVEF. Non-viability of the myocardium in the infarct area can induce fatal ventricular arrhythmia in the late period after previous MI. Next, here we see the outcome in patients with giant aneurysm. The incidence of stenotic lesion in the right coronary artery is shown in this slide. The incidence of stenotic lesion was significantly increased in the late period. In the incidence of stenotic lesions in the LCX was significantly lower than in the RCA and LAD. The overall survival rate in patients with the giant aneurysm at 30 years was 90%. The 30-year survival rate for bilateral GA was significantly lower than that for unilateral GA. The overall cardiac event-free rate in patient GA at 30 years was 36%. Note that the 30-year CE-free rate in patients with bilateral GA was significantly lower than patients with unilateral GA. The unilateral GA group consists of patients with GA in the RCA or LCA, and bilateral GA means the patient with GA in both coronary arteries. Furthermore, the 25 survival rate in post-AMI was 49%. The 25 survival rate in post-CABG patient was 92%. Furthermore, the 25 survival rate in post-CABG patient with a history of AMI was 74%, and for those without AMI was 100%. In summary, and not surprisingly, the outcome was significantly worse for bilateral GA compared with unilateral GA. The occurrence of myocardial infarction affected on the outcome in this population. In conclusion, myocardial involvement in patients with CAR caused by KD affects on the outcome, and it is the most important factor in the occurrence of late fatal ventricular arrhythmia. appropriate measures to predict myocardial infarction will greatly improve the long-term outlook for these patients. Thank you for attention.
Thank you, Dr. Suda. Although after invited lectures, we generally don't have questions, but since there is a lot of time available, and since there are many cardiologists sitting in the audience, so we could open up the session for some questions. Dr. Devra.
Thank you for this wonderful, wonderful talk, and we are quite mesmerized. And I just wanted to ask, when we are having children with moderate to large aneurysms, what are the factors which will give you the indication that this child needs a cath, that this child should go for an angiography? Not always we can do the stress testing, not always possible, especially in small infants. So clinically or by cardiac markers, is there anything that could tell us that other than the normal troponin, etc., is there anything that would indicate that this child will need a catheterization sometime soon?
Sorry. One more.
Small children, difficult to do stress testing.
Yeah.
So, if they have moderate to large aneurysms,
Yeah.
then what would make us think
Yeah.
that this child would need a cardiac catheterization soon? Even if the children are small, because it's very difficult to do angio in small children.
Yeah.
So when would you really go for a cardiac angio with the children, even if they're small, if it's small children?
Recently, to CTA angiography is recommended. In past, coronary angiogram was performed, but now CTA angiogram or MRA is recommended.
So we would first go for the CTA, and then depending on the findings, or a cardiac MRI, and then we will decide on the angiography.
Yeah.
Like invasive angiography.
Yeah. The diameter of maximal diameter of coronary arteries to 6 to 8 millimeter, more than 6 to 8 millimeter is candidate.
And for going for how soon, maybe around 1 year time, we should do a cardiac catheterization.
Yeah. To localized stenosis is detected, precisely localized stenosis is detected in coronary angiogram. For indication of CABG, I recommend it. Thank you.
For a given size of giant aneurysm, the different vessels have different rate of stenosis. Like the stenosis, this rate is more high with the LNC or LAN or RC. So do you have any observations like that? For a given size of giant aneurysm over a period of years, is there any difference in the stenosis rate or calcification rate depending on the vessel input? So, any observations like that?
Yeah. To severe calcification, with severe calcification, but stenotic region is not always detected. the end to severe calcification is a marker for follow-up in outpatient clinic.
I think the question is stenosis more common in right coronary artery, LMCA, left anterior descending, after a giant aneurysm?
Yeah,
Will stenosis be more common in one of the three coronary arteries?
Yeah, but occlusion of the right coronary artery occlusion of right coronary artery is likely to only 5 years after Kawasaki disease, and stenosis of left anterior descending is gradually after 10 years.
So you meant to say RCA?
Stenosis
occurs a bit early than the left coronary.
Yeah, occlusion, usually occlusion of the RCA is asymptomatic in patient. Sorry.
The new therapy, the primary intensification of therapy, after giving cyclosporine plus IVIG. So does the giant coronary artery aneurysms outcome changes?
I don't know about that.
Before the myocardial infarction, it will occur, most of them occur within 6 months of first year of life. So recent experience, have you seen any changes when you have used more drugs, not only IVIG, associated drugs?
Yeah, sorry, I don't know about that. Sorry.
I just want to know your experience about which artery you find the giant aneurysms common. Left anterior descending, RCA, and what is the usual course of giant aneurysm? Is it different in different arteries? Or follow-up?
Yeah.
The question is, giant aneurysms are common in which coronary artery? RCA, LMCA, LAD? In which coronary are the giant aneurysms most common?
Yeah. And how RCA, the instance of RCA and LAD are almost same, but instance of LCX is small. Small.
And ma'am, does it differ, the course of the giant aneurysm, does it differ according to the artery involved? I mean, regression of aneurysm, when you are following the aneurysms, when the person with regression comes, does it differ in the different arteries? I mean, the median time interval when it becomes median aneurysm, long time or small. The deviation, does it differ according to arteries?
Yes, the question is that if there is a giant aneurysm, does it make a difference in regression, whether RCA will regress more than LMCA or LAD?
About that, I don't know. I will try the study.
Come to the mic because it's being recorded.
So the material group, they reviewed their past echoes and they did the Z scoring of those echoes. And they observed which coronary regress faster. So it is LCX, the last one is LMC. And obviously the size also matters. But usually LCX regresses faster than the LMC is the last one to regress. That's number one. Number two, for supreme scoring, again, ma'am herself had a study. The size at second month from the onset of illness has a correlation with the long-term regression rates of the aneurysms. So if you intensify the therapy, at second month itself you may have a arrest of worsening of the aneurysms. In that way, it has implication in the long-term outcomes of aneurysms. So she herself had a study, I think it will be
And do you use beta blockers routinely to all the patients with giant aneurysm?
Yeah.
Do you use beta blockers
Yeah.
in all patients with giant aneurysm?
No, no. I used beta blocker in low left ventricular ejection fraction cases.
We had a patient with a giant aneurysm in which some remodeling had occurred, but I think around 8 years down the line, this patient developed a stenosis, which unfortunately we didn't pay much attention to. We didn't take notice of that. So this child, he was around 14 years old. He was very fond of running. So he went for a run early in the morning and dropped down while running. Retrospectively thinking, I think we should have got some intervention done. But it escaped us. It just escaped us. This was a child with, in fact, he had several giant aneurysms, but in one of them he had developed stenosis. Dr. Devdatta, if suppose you have to get an intervention done, how comfortable are you in getting interventions done in children with Kawasaki disease? What is the local experience in India?
I would be delighted to answer these questions, but from my experience, they are very limited because especially 1 to 2 children, 1 to 2 years of age, the intervention team is very, very skeptical about intervening in the organs. But if the child has got serious stenosis and has got disruption and has pictures of MI, then we have to give it a try.
How many CABGs have been done in Calcutta and Kawasaki?
Sir, I think it has been done 3 in NH, of which only 1 I had witnessed when I was a resident over there. The child had come, it was a 9-year-old boy who had come with severe epileptic dysfunction, and they found that the entire artery was totally fed by collatus. So, underwent a bypass that is being done right now. The other 2, I think, Dr. Bhatta has
Yes. So basically, from the giant aneurysms, giant aneurysms. So in our small experience over the past 20 years, we had 3 CABGs. One was a 9-year-old boy, and boy basically had a Kawasaki disease at about 2 years of age. And we diagnosed the child as a dilated cardiomyopathy. He came at 2 years of age. So we retrospectively we saw, we asked the mother, and she gave a very vivid history that he had a lesion very similar to Kawasaki disease. So when he came to us, it was a giant aneurysm, which I have a picture, I showed that part. Giant aneurysm, and which was totally filled. The LFC was totally filled with clot, and he already had a myocardial infarction, and as a result, he had dilated cardiomyopathy. So he went on for some time, and he probably it is very difficult to counsel. And he came back at about 8 years of age. He had a CABG, a graph from the Lima was taken. He went on quite well, and as madam was telling, thereafter, at about when he was in high school, at about I think 17 years of age, he was having recurrent ventricular tachycardias. And he used to go to school on a cycle, and he often be found at the roadside in an unconscious state. So he was again brought in, and then we had a ET study done. We could increase the ventricular tachycardias, and he was put in the ICD. Now he is about 23 years old. He is on a regular follow-up post CABG. his graft is functioning well, and he has his AIC has not really changed for the last 8 years, and he has been doing very well. The other children, we haven't seen stenosis as of now. We keep a very close watch because the common statement is just after the aneurysm, dilatation, we have a stent, we have stenosis. But until now, we haven't got any stenosis until now. From the international literature, and we have from my other colleagues who have seen, I think, only a few, what they do is, if the giant aneurysm is quite big and there is another chance, as well the literature says, the chance of aneurysm rupture is quite rare because it's protected by some coverings and other tissues and the tissues. But if there is a greater chance of thrombosis, they put a cover stent. The cover stent is easily available in India, they are very much used. We also use them, cover stents. And the length of the cover stent spans the whole length of the aneurysm. So the aneurysmal segment is converted into a normal coronary artery with the use of the cover stent. If the segment is stenosed, is included within that one, the whole process is normalized. But the child has to be on anticoagulants or antiplatelets rather for the lifelong. So that has to be this. Nowadays we have stents which can be re-guided. So even if it's a small child, then if you put the stent, that stent can be re-guided to an adult diameter at a later on stage. The third case, which one of my colleagues reported, from Gujarat, he had a small infant with a giant aneurysm with a clot totally occluding the coronary artery. So he went inside and we have a thrombossuction mechanism. So he thrombossuctioned the whole clot and the clot was taken outside. He didn't publish this case, but he's writing on it. He has a sensitivity scan done 1 year just during the clot formation and 1 year after that one, which has shown that the child has totally normalized now. The myocardial function has totally regained and the myocardial has been regained.
Suppose you have a stenosis in association with the giant aneurysm.
Right.
Are you comfortable putting the stent in, and will it be different from the patient who does not have Kawasaki disease?
No, the stent will be in situ, sir, and it will be like a normal person. Because after that one, we have eliminated the giant aneurysm. We have put the vein in between the giant, through the giant aneurysm and the stenosis part. So it will be normalized.
But these arteries are also prone to calcification.
Yes, sir.
Does that complicate the picture?
Not really, because calcification can occur, sir, but at the same time, we have to keep a very good watch, and with the calcification can occur, extracellular calcification can occur only when some of the plaques. When we allow the plaque formation, so to prevent the plaque formation, we try to put the child on antiplatelets and on atorvastatin as well.
Will you be able to prevent the calcification?
Not totally, but the chances of calcification, formation of calcification on the native coronary artery is also similar as on the stent. And if the calcification even occurs and these stenosis occur, we can re-stent it. It is documented. If the first stent re-stenosis, we can always put another stent.
What about road ablation?
Road ablation can be done, sir. In adults, road ablation is done. The only problem we have in children is the sheath size. That means whenever we go inside the heart, usually from children we go to the tubular artery. So the tubular artery has to accommodate that tubular artery. As if the child is a little bigger, we can definitely go for it. If the child is a little bit smaller, we will try to avoid that. Road ablation is a good part, but absolutely done when the child is a little bit bigger. So for small children, we go for it.
Dr. Devadan.
Case I have come across it is a 7-month-old boy. I will be showing it, but just wanted to mention 7-month-old boy with from severe cardiac dysfunction and heart was being treated as dilated cardiomyopathy. But I found that the child, in addition to the severe MR and the severe dysfunction, the child also had an aneurysm of the RCA. What was interesting is there was a flow acceleration in the proximal RCA. And when I did the coronary Dopplers, it came to be seen by coronary stenosis. And very interestingly, the troponins were high, that the ECG was also showing ST segment depression in D2-3 area. He had started on medications, but before we could go forward for any other intervention or anything, we lost our child to child of around 6 months or so with giant aneurysm. We gave that whole armamentarium of the primary intensification, and the child showed remarkable improvement and has been to PGI also, and now the coronaries have become almost small, like most of the aneurysms have regressed, and the largest one is like a small to moderate aneurysm within a span of 6 to 7 months. And that child also had a thrombus initially, had 3 days of admission, and we had put on the antiplatelets and anticoagulants also, 2 thrombi, blocking the LMC, and then maybe we should do this. So these 2 points I wanted to mention.
So again to highlight, the management of Kawasaki disease in many patients is lifelong management. And we have to keep on following them, and sometimes you come across surprises, and not very pleasant surprises. So with this we come to the end of the oration by Dr. Suda. We thank Dr. Suda for delivering this oration.
Thank you, ma'am, for delivering the oration. May I request Professor Singh and Professor Rawat to present Professor Suda with a token of our appreciation for delivering the Professor Lata Kumar lecture. Thank you, sir. Thank you, ma'am. Thank you. May I request everyone to join us for a cup of tea in the foyer? Thank you. We'll assemble in 10 minutes sharp, please.
ऊपर तो मिला है
Taru?
Okay.
देख लेते हैं खोल रहा है कि नहीं, जस्ट वो एक बार यहाँ पे देख पाएंगे।
हाँ ये तो हट जाएगा आपके वैसे में वो मैडम के लिए था, उनके लिए
ठीक है मैम, सब ठीक है।
नहीं ये नहीं चल रहा।
नहीं प्ले होगा, सब होगा मैम, डोंट वरी डोंट वरी।
अच्छा इसको पॉइंटर मिलेगा हमको?
हाँ इसमें ले सकते, उल्टा
बीच वाला पॉइंटर होता है, बीच वाला।
अच्छा अच्छा
ये हाँ 2 मिनट मेरे लिए छोड़ दीजिएगा मैम, आप लोग 2 मिनट मैम 2 मिनट मेरे लिए छोड़ दीजिएगा। मेरे 2 मिनट का ही स्लाइड है।
I'll just go through this like anything.
आप लगाओ इनको दे देते
लाओ मुझे बनाइए
आप भी
अरे बस
तीन तीन हो गया ना हाँ दे
एकदम
मतलब केडी वाला आ गया पीछे वेरी गुड Thank you, Matthew. बहुत अच्छी रहती ശരിയായിരുന്നു ഫസ്റ്റ് മാത്രം ഒരു വർക്ക് ചെയ്തല്ലേ മനസ്സിലായി അപ്പോൾ 17 മുതൽ 21 വരെ 4 ഇയേഴ്സ് ഓക്കെ അപ്പോൾ അതിലെന്തോ സീനിയർ സ്റ്റാഫിനൊക്കെ പിന്നെ നിനക്ക് എക്സ്പീരിയൻസ് സർട്ടിഫിക്കറ്റ് നീ എടുത്തായിരുന്നു എന്താ കാര്യം വെച്ച് കഴിഞ്ഞാൽ ഈയിടെ ഞാൻ ഇപ്പോൾ ഒന്നും ചെയ്യാൻ പറ്റില്ല പിന്നെ ഏതോ ഒരു ചട്ടപ്പാട് മാത്രം എടുത്തിരിക്കുന്നുണ്ട് അത് കളർ കോപ്പി എടുത്തിട്ട് അതിന് സീനില്ല ഞാൻ വിളിച്ചു 2 വർഷമായി അല്ല അത് മനസ്സിലാവും അതല്ലേ ഞാൻ എക്സ്പ്ലെയിൻ ചെയ്തു നിനക്ക് ഒഫീഷ്യൽ പേപ്പേഴ്സ് ഒന്നും വേണ്ട ഒന്നിനും സാരമില്ല നമ്മൾ പിന്നെ ഞാൻ നല്ല വിശ്വസിച്ച് പറഞ്ഞു പിന്നെ പിന്നെ ഇതിൻ്റെ ഇൻഫർമേഷന് കുറച്ച് വിശ്വാസമുള്ള സ്ഥലം നോക്കാൻ പറയും ഒന്ന് സഞ്ജീവിനിയുടെ ഡോക്ടർ പിന്നെ ഡോക്ടർ സാമിൻ്റെ അവിടെ ഒത്തിരി സമയം നമ്മൾ സ്പെൻഡ് ചെയ്യും അപ്പം നീ ഇപ്പോൾ എറണാകുളത്തായതുകൊണ്ട് ഒരു സജഷൻ മൂവാറ്റുപുഴ സഭയിൽ
सर आ रहे हैं बोल रहे हैं। We may now move to our next session, that is point of care cardiovascular assessments in KD. To chair this session, may I request Dr. Priyankar Pal to come over the stage. Dr. Priyankar Pal is Professor and Head Pediatrics in the Institute of Child Health, Kolkata.
So, I hope everyone is back after a couple of days. So, we have a couple of speakers over here for the session, and I would request Dr. Rakesh Vilani to start this one. So, Dr. Rakesh Vilani to come to the class. Rakesh, as you all know, is Assistant Professor of Pediatric Allergy Immunology and Lead. He has extensive publications, more than 100 papers in peer-reviewed international journals. He has received research grants from ICMR, PSC, International, and key areas of interest being Kawasaki disease. So over to Rakesh. Next is Dr. Devdatta Mukhopadhyay. Devdatta is a pediatric cardiologist, very well known in pediatric cardiology circles. She is now the treasurer of the Indian Society of Kawasaki Disease. She is an associate professor of pediatrics in the Western University of Health Sciences and a consultant pediatric cardiology in Apollo Hospital, Kolkata. We have then Rishika, Dr. Rishika Mehta, who is also a pediatric cardiologist from Narayana Super Specialty Hospital, Howrah. And the fourth speaker will be Dr. Amber Kumar, additional professor of the Department of Pediatric Cardiology, Pediatric Unit, Department of Pediatric AIMS Bhopal. So he is also the secretary of IIT Bhopal. So over to Rakesh.
Thank you, sir. So in this over 30 minutes, along with 3 pediatric cardiologists, I am a pediatric rheumatologist. So firstly, I am starting because what are the expectations from the pediatric cardiologist, and how echocardiographies are what is the point of care echo, and why we have kept this as a point of care cardiovascular assessment in KD, because you must be learning that echocardiography in Kawasaki disease is not a one event. We have to do many times. That's why it's a point of care assessment. So Kawasaki disease, the heart of the matter is that matter of the heart, because it's a disease which causes the cardiovascular complications, and therefore we are having this long-term follow-up and cardiovascular management of this disease. So the manifestation of cardiac involvement include in acute phase, subacute phase, and chronic phase. Several things are there, that it's a disease which is possibly a pancarditis, which have a mitral regurgitation, tricuspid, valvular regurgitation in form of mitral regurgitation, tricuspid regurgitation, and aortic regurgitation, then myocardial dysfunctions and pericardial effusion, and coronary artery abnormalities, which can be seen as a perivascular inflammation, ectasia, or a full-blown coronary aneurysms. So in chronic phase, we see coronary arteries sequelae because of coronary artery aneurysms, and cardiovascular involvement is Kawasaki disease is a wide spectrum thing. It's not just coronary artery abnormality, which has been highlighted several times. So we all know American Heart Association scientific statement, and which provides the guidance for the cardiovascular for the diagnosis and management of Kawasaki disease. And in this scientific statement, there are guidance for the how to do cardiovascular assessment also. So for to coming straight to the topic, that goal of echocardiography in a Kawasaki disease. So the two most important goal is that basically echo is the primary imaging modality in a Kawasaki disease, and for all patients with Kawasaki disease, with the diagnosis of Kawasaki disease, echo is to determine the degree of cardiac involvement. It's not for diagnosis. That's what I'm saying, because diagnosis is still a clinical thing, and in incomplete Kawasaki disease, when you have incomplete features, there is a role of echocardiography in a diagnosis. So if there are incomplete features and echocardiography is positive, that suggested this Kawasaki disease. Otherwise, the goal of echocardiography is that to know determine the degree of cardiac involvement. But the most important thing is that echo should not delay treatment, and we should not delay the treatment for a echo to happen actually. And second most important component during the acute phase is that echocardiography in Kawasaki disease during acute phase is a more of it involves several things, like sedation is a very mostly required in very young children, especially in less than 3. We use typically triclophos, pedicloryl, which is to sedate, because during the acute phase the children will be irritable, and due to the fever there will be significant irritability, and to do echocardiography in young children is a very tedious job. So, and it sometimes may required in older children also, because during the fever there may be significant irritability. And initial studies is a baseline for longitudinal follow-up for coronary artery morphology, LV wall motion, valvular regurgitation, and pericardial effusion. And so the initial echo should be done in the first week of illness is typically normal, because you may not see coronary artery abnormalities or coronary artery abnormalities in less than 7 days. You may see a myocardial involvement or myocarditis typically in the first week of illness. So imaging standards, I'm sure that cardiologists would be talking about, but echocardiography should be performed with equipment with appropriate transducer and with an experienced pediatric echocardiographer, basically who has a dealing with the pediatric children's, because doing echocardiography in children is more of like an art rather than science, because it's a patience, lot of patience is required, and sometimes you have to do for half an hour also in a young children, because children will take time. And the imaging should be performed with highest frequency transducer, and the probe allow these high transducer probe allow high resolution detailed evaluation for coronary artery abnormalities. And during the acute phase, the dynamic video or digital cine format should also be recorded, and the standard anatomic and physiological imaging will be dealt by the other speakers, and it should also focus on imaging the left main coronary artery, LAD, RC, and posterior descending coronary artery, and multiple imaging planes should be. So one coronary artery should be imaged in a multiple planes. It should not be taken in a one plane only. So these are the echocardiography views which has been given in the American Heart Association statement also. And the typical sites for coronary artery aneurysms are proximal LAD, proximal RCA, left main coronary arteries, and left circumflex. So typically in the sequence usually, and least often the junction between the RCA and posterior descending coronary artery. So the qualitative and quantitative assessments both are important, and measurement of coronary artery abnormality should be done in inner edge to inner edge, and they should not be measured at the bifurcation. And it should exclude pointing of branching, which may have normal focal dilatation, and absolute luminal dimension should be measured inner to inner edge. And we should also try to see whether these are secular aneurysms or fusiform aneurysms, because secular aneurysms have worse outcome with in the long run. So these are the coronary artery aneurysms of quantitative assessments which like now as per the American Heart Association statement, G-score should be used in all patients, and the G-score system, the most important with G-score is that there will be talk about these things, there will be separate session, but most important is that we have to use single G-score systems over the time. We should not change the G-score system in different, because there are several G-scores are available. Similarly, in 2020 JCS guidelines also, they have also started using GCS, but as per JCS, the Japanese Ministry of Health, they are not still using G-score 2225 as a dilatation. But typically, the typical definition of coronary artery aneurysms, which stands true possibly today also, because that large aneurysms are 8 mm in inner diameter, if it is more than equal to 8 mm is a giant aneurysms, and typically if you see the long-term complications are associated with aneurysms absolute diameters of more than 8 mm. So coronary artery involvement, another definition for coronary artery abnormalities are if you see the diameter in like dilatation with an internal diameter of segment measuring less than 1.5 times that of an adjacent segment. So according to adjacent segment also you can define the coronary artery abnormalities. So coronary artery involvement, there should be Z score should be used, and the Z score should be continued, same Z score should be applied in several settings. So the cardiovascular assessment in a Kawasaki disease should not be limited to the coronary artery involvement, and it should go beyond that. That assessment of ventricular form and functions also should be looked, and assessment of aortic root, assessment of pericardial effusion and valvular regurgitations should also be. So these are the recommendations for cardiovascular assessment, which I have already highlighted. So Dr. Debatata will go further into this.
Thank you so much, Dr. Rakesh, for the wonderful presentation. A very good evening to respected chairperson, Professor Shudha, Professor Singh, and all the audience. Let me briefly touch upon the various aspects of point of care. Firstly, if the child comes, I would like to see whether the child is having any symptoms, whether there are any complaints of excessive crying or any other conditions there, and also check for the hemodynamic stability. And that will be discussed again by Dr. Ambar. And echocardiography, as discussed, forms the cornerstone. In that list, I would definitely add valvulitis. And of course, depending on the findings, we go for advanced imaging. Cardiac enzymes, biomarkers, and inflammatory markers are point of care tests which would help in the supporting the diagnosis. And of course, in the long term, we would be asking for stress test, and including an ECG in the follow-up is very, very important. So with all this, I feel like I'm one of those 6 blind men who are trying to decipher the elephant. This is the holy grail of the whole thing, the various coronary arteries and their various views. And just to mention, when we take the pictures, we must increase the frame rate, reduce the sector width, reduce the depth, and for every measurement we should zoom on the focused area. Harmonics should be put on the lower side and increase the compression settings for better resolution, and of course use a higher frequency transducer. We have to look at the other views of the echo as well if we are missing any other things in the echo like valvulitis or function, assess the function, which I'll discuss, and also any thrombus. So we do have to put the color flow in the coronaries, because sometimes we may come across the pericardial sinuses, so those will not have any color flow in them, and we have to put the color flow in such an angle so that the beam is parallel to the course of the coronaries. Here it's demonstrated, and I would like to bring your focus to this bit, because sometimes if in an ideal setting the child is quiet or well sedated, this is the normal coronary flow. But if we have a high resting coronary velocities by the pulse Doppler, that indicates probability there is a stenotic lesion, and usually we put in the Nyquist limit 30 or below.
This is the place where you can see the color flow velocities are very, very less to get the low flow velocities in the coronaries. And these are the other views you can, sorry. These are the other views where you can see the LMCA coming out from the aorta and also the RCA. This is the apical four-chamber view. And also the parasternal long axis view showing the RCA. It's slightly tilted forward. This is the pulmonary artery and this is the right coronary artery. And this is the circumflex in the atrioventricular groove in the sort of the modified four-chamber view. This is, I would just show you this. This is a child who had coronaries of all four of the coronaries were in quite enlarged, having giant aneurysms. And the upper two of a child we saw in December with large aneurysms of the LMCA and the LAD. And we are not measuring at the bifurcation. We are measuring end to end, somewhere in the middle, not at the origin, not at the bifurcation. So that's it. And that's the same child who had a thrombus. On day 3 of admission, we found thrombus in the LMCA as well as the LAD. And that was quite scary for us. Troponins were normal, however, and the ECG was also normal. Did remarkably well after the initial primary intensification of therapy and the host of anticoagulants, and is now having just a mild dilatation. And this is another child initially seen by Dr. Pal and is also following up with him, and had large giant aneurysms in the LAD as well as the LMCA. So, and also fusiform aneurysm over there in the proximal right coronary artery. So, this is another modified view of the coronaries showing the apical view, and this is the LAD in the interventricular groove. This is a normal size LAD, but slightly dilated maybe, but you can see, appreciate this huge, this is the aorta, and from this aorta, this huge vessel is coming down. This is the dilated LAD and of the giant aneurysm, this bit. This is the aorta with the valve, and this is the giant aneurysm that is coming down in the LAD. And we have to be aware again of, we are not measuring anything else like the pericardial sinuses. Also, we need to look at whether there is coronary veins, because the diseases that are affecting the arteries will be affecting the veins as well. The direction of flow will be different. Osteal stenosis, myocardial bridge, they may be like misinterpreted. And also we have to look for, is there any abnormal origin of the coronary arteries, like the interarterial course and the intramural courses. So, and this is a child again who at around 3 weeks of age only presented with this kind of a narrow stenotic, potentially stenotic lesion at the proximal LMCA, then had dilatation and also LAD was dilated, shown much better on the CT done by Dr. Singhal in PGI. So just to highlight 2 cases from Professor Shabui sir, and there was this child of 11 years who had come with as a follow-up after 1 week. And initially LAD was mild dilated and everything else went very well clinically. But when I did the echo after 1 week follow-up, there was this large thrombus sitting in the RV. The child had to be readmitted for, again, the anticoagulants. Then did well and it disappeared subsequently. And this is another child of 9 years, came with septicemia, hemodynamically unstable, required inotropes fluids, had pus aspirated from the joint, had septic arthritis, and this was the LMC and the LAD coronaries. Also had pericardial effusion with strands, and because of that effusion, we were getting this ST segment elevation globally in the ECG. So this is another child which I was alluding to in the discussion. You see this, there's severe dysfunction as well as MR, possibly because now I realize could be because of the partially torn chordae. And here, this is the RCA, and there is this flow turbulence in the proximal RCA with a fusiform dilatation in the mid RCA.
And we can see the ST segment depressions in 2-3 AVF leads, which are actually representing the RV as well. So there's dysfunction and also RCA stenosis, and this is the coronary flow patterns showing high flow reserve and definitely a stenotic lesion. We lost this child to ventricular arrhythmias before we could go for further investigations. And this was the conventional way of assessing the cardiac systolic function, the Simpsons and the M mode. But what I would like to highlight in the follow-up, I think somewhere down the line we need to do the strain patterns. Strain will identify the individual regional wall motions and also the speckle tracking over here, which can be of 3 types. This is the GLS or the global longitudinal strain. We also have the radial and the circumferential strain. But usually in the KD patients, the longitudinal strain is more affected and has been found to be an accurate marker of myocardial involvement. Circumferential strain is not that used. And in this beautiful paper in BMC, they did a long-term follow-up where they found even those without coronary artery disease having a history of KD initially, even they had a significant lower strain. So this is the child with the history of KD with coronary artery involvement, with no coronary artery involvements, and the normal. You see these blue areas are indicating regional wall motion abnormality in these segments of the myocardium. So just to finish off, we need to do some stress testing, which can be done by exercise or MRI or SPECT. MRI or SPECT is more of Dr. Singhal's department, so I won't mention those. But exercise stress testing has been found to be very effective in identifying or prioritizing or building up a, identifying those at risk, definitely. So this paper has beautifully given a sort of a practical workflow for the cardiovascular assessment in KD patients. And from Dr. Jane Burns and her team, exercise stress test echocardiography was assessed in children with KD. And even at 14 years, 8 years, or 6 years down the line, they have found these kind of changes in the coronaries. So if a child comes with symptoms, it is very difficult to understand. So unless we are very much aware, we might miss, because the child will be with some ischemic symptoms. They will just be, especially infants, will be irritable, crying, restless, vomiting, and maybe just have breathlessness. So ECG is important to identify, and this is the protocol given for the myocardial infarction in children. The biomarkers will be very helpful to us because cardiac troponin initially rises 3 to 4 hours and then settles down around 2 weeks, 1 to 2 weeks. And serial measurements will be very helpful. And of course, NT-proBNP is an important marker initially in the acute stage, definitely. And from Dr. Pal's study, we have that it is definitely higher in sepsis and other febrile illnesses, but more higher in acute KD. So just to ponder over these points at the end, we need guidelines to identify children who in the long term will be at risk and assess for signs and symptoms in them, detailed echo evaluation, and of course include stress test in the follow-up and go for the point of care tests, the biomarkers, etc. And again, advanced imaging as per guidelines. But I was just wondering, what do we do for the peripheral vessels? Because do we go for pulse Doppler velocities? Because we do not have definite guidelines or even suggestions like what should make us look for the peripheral, assess the peripheral vessels. So with this, I would call upon my next speaker. These are my fangirl moments here. So I'd call upon Dr. Rishika Mehta to discuss the imaging beyond the coronaries. Thank you.
Thank you, ma'am, for the wonderful talk. Most of my points have already been covered, but there are still some points which I would like to highlight. That since morning we have been highlighting on the fact that coronaries, there is something beyond the coronaries in Kawasaki disease. So in order of the frequencies, apart from the coronary artery aneurysms, myocarditis, which is invariably present in 90% of the patients, who are almost 80% of time asymptomatic and 20% of times present with LV dysfunctions. Pericarditis with pericardial effusion, though it is rarely reported but has a lot of importance. Systemic arterial aneurysms, valvular diseases, that is since morning, which has been highlighted on the point that endocarditis is a common manifestation in KD. Mild aortic root dilatations reported in 10% of the cases, and myocardial infarcts. So myocarditis, it is one of the earliest presentation of Kawasaki disease, which presents within the first 10 days of illness, while we start to see the coronary involvement after the 10 days of illness. So when babies present to us with myocarditis in first 10 days of illness, high suspicion of KD is to be there in our mind, and it develops as a result of mostly inflammation of interstitial tissues. So as I said that myocarditis, mostly it is asymptomatic 80% of times, and that's why it's easily missed. And in the other 20% of cases where the patient present to us with unexplained tachycardia, congestive heart failure, hemodynamic instability, and who requires high inotropes and present with arrhythmias and they cause significant morbidity and mortality if the myocarditis is symptomatic. And there is a thin line of difference between viral myocarditis and KD-associated myocarditis. Patients in a viral myocarditis present to us after following a prodrome, and at the time of presentation, mostly they are afebrile, while in KD-associated myocarditis, patients develop myocarditis early in the phase, and it is accompanied by high-grade fever. And while in KD-associated myocarditis, they usually respond very well to IVIGs, while in viral myocarditis, they poorly respond to IVIGs. What is the role of biomarkers? NT-proBNP has been repeatedly used nowadays for the patients who present to us, and serial measurement of NT-proBNP is very important. So there have been studies where cutoff levels of 1025 of NT-proBNP has been taken care of, and serial measurements of NT-proBNP has been taken care of. And it correlates very positive with C-reactive proteins hypoalbuminemia during the initial phases of disease. And as we know that it has a negative correlation with the LV ejection fractions, fraction shortening, cardiac index, and diastolic function. And cardiac troponins and CPKMB. Troponins have a high specificity and CPKMB has a high sensitivity for this. Pericarditis, as I said, that it is common but underreported, usually mild and not significant. Pericardial effusion, whenever we get a patient of pericardial effusion, we usually suspect a high degree of KD, as if the pericardial effusion increases and it goes towards tamponade, it is usually fatal, because most of the times if cardiac tamponade is present, it may be a component of polyserositis or may follow rupture of coronary artery aneurysm in the pericardial cavity. And mild pericarditis, it often resolves with IVIG and aspirin. So valvular abnormalities, in acute phase, it is integration of pancarditis, but persistent valvular abnormalities due to valvular dysfunctions and pap muscle dysfunctions due to coronary ischemias caused due to myocardial inflammation mainly. And most common abnormality which we always see is mitral regurgitation during the acute phase of KD, which resolves on follow-up. Some patients who develop severe mitral regurgitation, it is due to chordal rupture, and it causes rapid clinical deterioration and usually fatal if not taken care of. Aortic root involvement reported in almost 10% of patients, and root size correlates with coronary diameters but not with the inflammatory parameters. Sometimes patients with severe AR have been recorded to undergo valve replacement later in life because there is an increased stiffness of aorta and decreased in the elasticity, which causes functional impairment of the aorta, and it is observed both during the acute state and the chronic state. So this is the point which I would like to highlight. We usually take care of the ventricular systolic function, but also diastolic dysfunction has been reported. So nowadays with the machines, we can measure the LS LA strain also, which is a very good marker of the diastolic dysfunctions. And left ventricular systolic dysfunctions, apart from the M mode, we usually go for the speckle tracking images, which is much more sensitive and it comes much more earlier than the decrease in the ejection fractions. So we typically almost always try to do the speckle tracking images in all the patients who present to us with myocarditis. Secondly, regional wall motion abnormalities are obviously a surrogate marker of coronary involvement. And in even those patients who come to us with valvular regurgitation, we typically take care that we always do the speckle tracking images. It has been found that in the apical strain, if it comes down at a lower levels, it is mostly a marker of Kawasaki disease. Aortic root diameters we usually take in the first 10 days, follow up after next 2 months, followed by 6 months till 1 year of age, if everything goes fine. Left atrial stain, as I already insisted upon, diastolic dysfunction has also been reported in cases, so we take care of that. And pericardial effusion we try not to miss. Next, I would call upon Dr. Amber for the further things. Thank you.
Thank you and good evening, everyone. So after an extensive talk by all my co-speakers, so I will talk about basics only. So coming back to the basics in this session, because in 5 to 7% cases of Kawasaki disease can present with shock syndrome. And looking at the heart rate, blood pressure and peripheral perfusion is also very important. Otherwise, you can treat like a septic shock in these cases. So Kawasaki disease shock syndrome, this is defined as sustained presence of any of the following conditions requiring volume expansion, inotropic agents or transfer to ICU in a suspected case of KD. So either systolic hypertension for the age, this cutoff is as per the ALS guideline, advanced life support guidelines, or we can use the nomograms also, or decrease in systolic blood pressure from baseline of more than 20%, or clinical signs of poor perfusion regardless of normal blood pressure, like tachycardia, prolonged CFT, cool extremities, diminished pulses, oliguria, and mental status inappropriate to other conditions. So the Kawasaki disease may be the presenting feature in 5 to 7% case patient. This is Western data. We don't have Indian data, and I have searched literature. We could not find any RCTs on this Kawasaki disease shock syndrome. So probably later on we can get the Indian data also. So children with shock presentation appear to be at highest risk of IVIG resistance, coronary artery abnormalities, MR, and prolonged myocardial dysfunction. And they are commonly presenting with elevated CRP, less albumin, and thrombocytopenia compared with the KD without shock. So in such cases, when bacterial cultures are negative and fever persists, the diagnosis of KDSS should be considered. And the shock in these patients with KDSS can be cardiogenic, distributive, or mixed. So this is very important part. So any child presenting with shock and we are suspecting Kawasaki disease in this case, then it can be cardiogenic because of poor myocardial function that we have already seen in our previous sessions. It can be distributive. The distributive component of shock might result from high level of circulating inflammatory cytokines, vascular endothelial growth factors that lead to the capillary leak, and vigorous volume replacement without concomitant anti-inflammatory therapy, that is the IVIG, that is the cornerstone of management, can result in complications from interstitial fluid accumulation. So once we diagnose it's a shock and the underlying cause may be Kawasaki, then first step for the management is to look for the fluid responsiveness. And again, this is the point of care ultrasound, point of care test. We can find out whether the Kawasaki disease shock syndrome, this case, is volume responsive or not. So we all know these are basic tests like IVC collapsibility index and distensibility index. And the recently nowadays we are looking for aortic flow velocity variability and LVOT velocity type integral. These are more sensitive marker for volume responsiveness. So based on these tests we can decide if the child is volume responsive or not, and then we can manage. The next step is decision on the inotrope. Again, this is important to look for the point of care ultrasound. And we have already seen if the child is hypotensive with no cardiac dysfunction, then we can start any inotrope with pressure support. But suppose hypotension and cardiac dysfunction both are there, and we are starting only pressure support like norepinephrine with very poor beta action or vasopressin, then we are increasing the peripheral resistance in a failing heart. So this is not good. So that part we have to take care with the help of point of care ultrasound available with us. And if in that conditions, we have to add Melanon in these conditions. Now coming to the second point of care test like ECG. So like other atypical presentation of Kawasaki disease, ventricular arrhythmias is also a rare atypical presentation of Kawasaki disease, and if misdiagnosed, the development of aneurysm is increased to around 25%. This is already the same data. And if you see the rhythm abnormalities in case of myocarditis, these are non-specific ST and T changes and low voltage complexes because if there is myocardial edema or pericardial effusion. Inflammation of conduction tissue can lead to any arrhythmias, ventricular arrhythmias or block. Myocardial ischemia can also lead to the any myocarditis and myocardial infarction. So such sign has important role in immediate follow-up imaging and biochemical check in plasma for cardiac enzymes. So the last part, the summary of this hemodynamic assessment, since the Kawasaki disease can manifest before the diagnosis of Kawasaki disease, so it's very essential to recognize the early signs of Kawasaki disease so that IVIG therapy can be initiated promptly, and the treatment of underlying inflammation IVIG and hemodynamic escalation with fluid and inotropic support to tide over the crisis period is important in resolution of KDSS. And role of ECG in KD is limited, but the prompt identification of rhythm disturbances and timely management is crucial in sick patients. Thank you.
So, any questions from the audience? We have some time? Yes.
One of the slides you have shown echocardiography.
Speak to the microphone.
One of your slides, you have shown an echocardiographic image where you told about there was a lag dilatation and stenotic lesion in aneurysm. So, how to tell about echocardiography?
It's very difficult, but I think ECG would be a very, very good pointer. But not all stenotic lesions will produce a ECG in the resting child. For that, we need the stenotic lesions. But the answer to a question, if the child is symptomatic also, then also it means that we should go for an ECG and further evaluations. And definitely, I think all children with these kind of, all children with KD on follow-up should have ECG at some point of time, at least at regular intervals. Okay, and because the features are very non-specific. Another point is that if you have an, like I said, if you have a very ideal settings in well-sedated child or a child who's very cooperative, you'll be able to do the coronary flow reserve. So the coronary velocities, a resting high reserve will indicate a stenotic lesion. Ectasia means mild dilatation, like aneurysm will be 2.5 to small aneurysm 2.5 to 5 z-scores. So anything around 2 to 2.5 going slightly borderline cases, those will be ectasias. No. Pardon? I do not have a number to that, but recently I have seen a few cases with small and moderate aneurysm presenting with junctional rhythm in follow-up, and those junctional rhythms are very infrequent. They are coming 1 or 2 times, a few rhythms are junctional and the rest of the time it's a normal sinus beat. So sometimes we need to keep our mind open and go for a Holter also, I think. But that is if you come across these things, and one baseline ECG would be very important, I think. I'll just make a comment over there. How old was the child? Sometimes in newborns or infants you have the atrial ectopic tachycardia. That is very similar to the sinus tachycardia, but the rates are very high. It is from an ectopic focus which is very close to the normal sinus node. So if you have that, it's very difficult to differentiate from the normal sinus rhythm, excepting for the fact that the rates will be consistently high, like 190, 190, not variable. That is the thing, is that in those cases you have to use beta blockers, may use amiodarone, but mostly it responds to ivabradine. Ivabradine is being used very commonly for those. But yeah, probably because of Dr. Amber mentioned about the inflammation bit of the.
So, sir, just one comment. Myocarditis is basically the inflammation of myocardium. So that will lead to the ST and T changes. So baseline ECG is important to differentiate ST and T changes. And the next is, if myocardium is inflamed then and edematous, then it can lead to the low voltage complexes. Otherwise, low voltage complexes are more common in pericardial effusion. Now coming back to the tachycardias, if the heart rate is more than 220 in an infant, then we can consider it as a SVT, but we have to look for whether RR interval is fixed or not. If RR interval is fixed and it's not responding, even on stimulating the child, the interval is not changing, then it most likely towards SVT than normal sinus tachycardia.
One thing is that as far as the function is concerned, if we can do a strain properly, it would give us, and if there is any regional wall motion abnormality, that can give a fair idea, but it is very difficult to differentiate. And about the valvular regurgitation bit, if there is, like we have a severe MR or moderate to severe MR, if there is partial tearing of the cordae. And I think Dr. Sudha can give you about from her vast experience, she can give you more information, and Dr. Chattopadhyay wants to add.
What's asking probably that whether you can understand the grade of myocardial involvement by the echocardiography alone, if I have interpreted the question correctly. So what Dr. Devdutt is telling, there are two major modalities of treatment, echocardiogram. One is the 2D, where we have mentioned is the regional wall motion abnormality, which you can see just upon on the screen. So when the regional wall motion abnormalities are already present, that means there has been some good amount of coronary involvement. But apart from that, there might be subtle amount of myocarditis or even myocardial ischemia ongoing, which can only be captured if you do the stress and strain imaging. So to capture those at very early stages, probably you will need a stress and strain imaging. And what is the practical utility? Practical utility is, will there be any difference in treatment which you are already doing? Because what Priyankar was telling is that the major modality of treatment is the IVIG and the corticosteroid and the other anti-inflammatory medications. Most of the symptoms and the major manifestations come down with the decrease of the inflammation itself. Like is even the tachycardia or arrhythmias will come down with that one. But if it persists, then what to do? There you have to escalate your myocardial therapy. If there is dysfunction, you go on increasing the inotropes. Obviously, one thing we have to remember is any inotropic therapy, by virtue of its nature, any inotrope will increase the myocardial oxygen demand, cellular oxygen demand. So they are also detrimental. So we have to maintain a balance. I think doctor told, one of the speakers told about a milrinone. So adrenaline, noradrenaline, or even milrinone to reduce there should be a perfect balance with the preload, afterload, myocardial contractility, and obviously the myocardial perfusion as well, which you maintain with the antiplatelet and anticoagulants.
And, thank you, sir. And I think we must remember that all these inotropes can increase the stress on the coronaries as well, because they will be increasing the oxygen demand on the heart, and all these will be pro-arrhythmogenic, most of them also. So it's a very delicate balance which inotrope to give in which condition. Thank you.
Thank you, speakers. So we move on to the next session.
For the next session, that is limitations of echocardiography for the assessment of coronary arteries in KD, may I request Professor Sujit Singh sir to please chair the session.
So in this session we have two speakers. So we'll start with Rakesh first.
किसमें है? पेनड्राइव लगाया मैंने।
ये खोलो।
कावासाकी?
हाँ कावासाकी।
पावरपॉइंट है?
हाँ पावरपॉइंट है नीचे।
किसी फोल्डर में?
न्यू माइक्रोसॉफ्ट पावरपॉइंट है उसका नाम, फोल्डर का नाम न्यू माइक्रोसॉफ्ट ये।
ये ब्लैंक है क्या पहले?
So good evening all. Again, so after discussing the echocardiography, that point of care echocardiography, we should also know that what are the limitations of echocardiography, and like because that is also very important, and me and Dr. Amitabha will be discussing that what are the limitations. I will be just discussing the limitation part, and there will be real life scenarios by Dr. Amitabha, and why it is important to know that what are the limitations and when should we go beyond the echocardiography. So the role of echocardiography is that its importance of assessing coronary artery involvement, and it's a first line imaging tool, and it will be used commonly, and it will be used first line, and it will be used more frequently because of the nature of availability, and it will be used for serial monitoring, and it's safe, non-invasive, and widely available, and there are no side effects available or no radiation exposure as seen in several other modalities. So, but the major limitations of echocardiographies are that it's limited visualization of distal coronary arteries and left circumflex, and we have seen multiple times that you can't see distal coronary arteries very well in echocardiography, and almost most of the time seeing a left circumflex especially in older children is very difficult in echocardiography. And second thing is operator dependency, and more so in children, because in young children doing echocardiography it's again require a lot of skill, and it's more of patience rather. And then inability to assess the coronary artery stenosis or thrombosis, because many times to say that it's a stenotic lesions, it's a difficult thing in echocardiography, and you have to perform several other imaging, and there are challenges in older children or obese patients because you may not be able to get a appropriate window. So the limited visualization of distal coronary arteries is because echo is very good for proximal segments, and the distal coronary arteries and branches are often very poorly visualized, and it is because of the interference from the lung and rib artifacts, and possibly you can't see the distal coronary aneurysms, distal coronary segments in all patients. Sometimes you can see in several other views which will be discussed by Dr. Amitabha, and that there are limit. And then second point is that because you may be able to see the proximal aneurysms, but sometimes we can't see the distal extent of the same aneurysms, because it's also important that we have to see the extent of that aneurysms, and sometimes one coronary artery can have several aneurysms. So if there are several 2 to 3 aneurysms, these will be the complex aneurysms, and visualization and detailed visualization is essential. In that echocardiography may fail actually. So transition to normal size coronary arteries, and it may estimate the true burden of the disease because of the Kawasaki disease. So we have shown previously that the distal coronary artery abnormalities in Kawasaki disease can seen, and it's because the usual conventional thing is that KD involve proximal segments only, but it has been shown that the distal coronary artery abnormalities can be seen in KD, and sometimes they can seen in isolation, because in isolation in the sense that proximal coronary artery may have resolved at that time, or typically just a distal coronary artery aneurysms was there, and these coronary abnormalities may not be able to pick in echocardiography, and these settings there is a role of further imagings. Limitation in assessing the left circumflex coronary, limitation of in identifying the coronary artery thrombosis and stenosis again has been shown by Dr. Debadatta also, that you may see that there are several views that in one of the patients he has shown that it looks like a stenotic lesions, but further when we did the CT coronary angiography in that patient, there was no stenosis, so it has to be confirmed by further imaging. So echo is not foolproof in identifying the stenotic lesions. So sometimes when you are treating Kawasaki disease and you are looking for coronary artery abnormalities, and you are doing echocardiography, and you may miss congenital malformation and misdiagnosed as a coronary artery abnormalities. So because congenital aberrations and congenital anomalies are also there, and one of the patients we have seen that the infant came with the fever and like all the signs of Kawasaki disease, and the infant had a significant myocardial dysfunction, but that myocardial dysfunction has not improved with IVIG completely, and that baby had L kappa at that time. So it's possibly that we are dealing with congenital malformations, and if you are looking for the coronary artery abnormalities in echocardiography in a Kawasaki disease, possibly you are not looking for those L kappa and all these things. So in that situations, if there are congenital anomalies, it may be missed, or it may be understated in that case. So this is a study from Tekokupus group, which is also prefer the CT coronary angiography in Kawasaki disease, and they have shown that echocardiography underestimate the coronary artery abnormalities in and if you can see that these were the coronary artery abnormalities which were completely missed in echocardiography, and which has been detected by CT angiography. So echocardiography is a first line but has limitations, and we should know what are the limitations, wherever we have to escalate or where we have to go beyond the echocardiography, and other imaging modalities are needed, especially in high risk patients or where we have to do a detailed coronary artery assessment. So there are importance of multimodal imaging approach for optimal coronary artery assessments. So further, I would invite Dr. Amitabh Chattopadhyay, and we'll take a question after that.
Good evening, everyone. So limitations of echocardiography. So there are obviously, it's time, I think it's almost 5:30, the IPL session, opening session is going on. So as in a cricket team, you all know that we do not have all the all-rounders. We have a specialist batsman, we have specialist spinners, and obviously we have fast bowlers. We have to have a mix and match. So the patient and the doctor both have to be patient. We'll be inspecting structures measuring 2 to 3 millimeters. Obviously, one of the main things which we are forgetting is we are inspecting a heart which is beating at a rate of 120, and with crying it is at 150. So imagine a bowler bowling at a speed of 140 and a batsman without a helmet facing it, just like Sunil Gavaskar. So we have a cranky child. Usually they remain irritable with the fever and the associated illness, and we have this position. So the doctor is positioned either like this or maybe like this. So the machine, the knobology, and the person behind the machine. I'm going to talk about the echocardiography portion. So again, a heart bracing at about 150, and आजकल तो IPL में भी 5-6 एम्पायर रहते हैं. पहले 2 umpire रहते थे. Yes, now we have 2 specialist umpires sitting on the TV, and 3 specialized umpires on the ground. So we have to utilize the best of the machinery and the best of the machines which we have. Obviously, we have to select the probe, a proper probe, a finer probe with a higher frequency and a proper frame rate. We have to increase the frame rate as high as possible. Just like in the CT scan, if we do the CT, which sir is telling that if we do the CT at the 64 slides, the most of the information will not be available. So we have to keep pace with the heart rate and obviously the rate at which the heart is beating. So minimal is 128, 256 is for the better. Proper depth and sector width. We have to increase the depth or optimize the depth in such a level so that the heart, so that the coronary arteries are brought just to the surface, turn the patient and baby to the left as much as possible unless there is a dextrocardia, and the sector width has to be minimized so that the best of all the pixels are concentrated on the same phase and the best of the pictures is brought out. We can adjust the contrast or the compression, as Deepta was telling, to bring in a crisp image and reduce the artifacts as much as possible by using all the knobs whichever is feasible. So this is a knobology. I have got a comparison of 2 pictures. The same picture on the right side, you have the same picture. On the right side, on the left side, you have the same picture, but all the knobs have been adjusted. You can see the coronaries are almost standing out. But in the picture on the left, the coronaries are almost subdued, so that the rough assessment is done. So assessment of the coronary arteries. Measure after a magnification, we can zoom it before that one. Otherwise, just like whether the batsman is run out or not, we have to make it in slow motion and we see it in several number of times. Inner edge to inner edge, perivascular cuffing, which is subjective. So the perivascular cuffing is not actually included into these dimensions. Don't measure the bifurcations and take multiple views as much as possible. Now take multiple views, there's one point worth it. Suppose we measure plenty of patients, because one of the relatives once told me that डॉक्टर साहब क्या किया आपने पिछले बार 2.3 मापा था अभी 2.6 है 3 महीने हो गया क्या दवाई दिया कुछ तो कुछ नहीं हुआ. So this is a practical experience which I am telling. Plenty of parents, they feel that 2.3 and 2.6 does make a huge difference in life. It is very difficult to explain them practically because 2.3 and 2.6 won't make much of a difference. But what we do is, suppose the same observer at the same setting takes 3 measurements and I bet they won't be equal. So we try to average it out at different positions, different multiple views and multiple postures. So as you can see, difficulty in visualizing the coronary is too small and maybe included and they are moving. So there are turns and bends. We have to see whether clots inside and to make crucial decisions. Like this crucial decision, batsman is not out. It's very unlucky. The ball did hit the wicket, but the bell did not fall. So appreciation and measurement of aneurysmal segments, serial measurements and standardization Z-scores, preferably by the same observer, but sometimes it may not be possible. Suppose the same patient comes again and again, and in the OPD, we have one echocardiography in one instance, and we have another echocardiography in another instance. So delineate the branches very quickly. This is just an example. See, the heart is beating at about 130 per minute. I don't have the ECG here. And this frame has been stopped and the frame on the right side has been derived. So this is a full motion and this is in a still fracture which has been derived from the motion. And obviously it depends on the observer bias and obviously at the frame rate and the frame which you are choosing. So aim and shoot. So you can see the left coronary artery aneurysm, the same thing, we have stopped and we have measured the aneurysm in 2 different views, 2 different dimensions. So perivascular cuffing. See, perivascular cuffing is quite subjective. Obviously, on the first frame, you see there is a good amount of perivascular cuffing, which is some amount of tissue which has been adhered. And on the second picture, you can see there is a small aneurysm just after the bifurcation followed by the LAD. So this is the cardiac function. When we assess the cardiac function, this is a myocarditis associated with Kawasaki disease, dilated and the function is somewhat subdued. On the right side, we have a good cardiac function, so the function has not been affected as of now. Pericardial effusion. Obviously, this pericardial effusion is rare, but you do get it at some times. And turns and bends. As you can see, this picture was taken by me a long time back. As we stand on the Nadi Kinare, and on the banks of the river, we can see only a forthcoming, we can see only up till some certain extent. And this is a normal coronary distribution. Obviously, the coronaries circumnavigate all around the heart, and obviously, it's not possible for us to see beyond a certain limitation of the coronary arteries. Luckily, as my previous speaker said, very luckily, maybe the creator also listened to us, that most of the coronary aneurysms occur almost 80 to 90% within the first almost 1/3. So what happens to the distal ones? To see them, obviously, we need either
a circumnavigate echocardiogram which is yet to come, or maybe we have to take help of some other digital mode. So this is a valvular regurgitation with some amount of dysfunction, and on the right frame you have some amount of dysfunction associated with some amount of mitral regurgitation. And delineate the right and the left coronary systems. So as you can see, these are all the still pictures. This is the boy which I was telling in the afternoon. There is a huge giant aneurysm which is totally occluded by a huge thrombus. So he presented with a myocardial infarction, and he came to us with a giant aneurysm totally occluded with a thrombus. So as we can often say that if you do not see the coronary arteries in a very small thing, see just now, Dr. Debabrata was mentioning that how to understand the stenosis. The structure already is 2 millimeters, and even a small infant it might be 1.5 millimeter. उसको ऊपर stenosis क्या? So what happens if there is really a stenosis? It's extremely difficult to find the flow, but definitely we can invite some other things. So you can use the colorization judiciously. We can use different forms of color on the echocardiogram to bring out the contrast as much as possible. For example, in the blue picture, you can see the echocardiogram is much more, the coronaries are much more standing out, and on the left, in the sepia color, you can see. So check from all angles. As you can see, on the first frame, the left coronary artery is actually not seen. We are seeing the right coronary artery. Whereas on the left frame, you can see the right coronary is not seen, but the left coronary artery is seen along with the small aneurysms, which should not be missed. So check the flows. Obviously, even when you delineate the arteries, we have to check the flows. This is the posterior descending artery, as you can see in the first frame, and here you can see in the left coronary artery, there is an aneurysm, and the coronary artery flow was seen just beside it. We have an aneurysm on both the systems, at the right and the left. So here, how do we compare? Now the Z-scores and other measurements come to this thing. Pediatric multisystem inflammatory syndrome, temporal acid COVID-19. I think we have discussed the coronaries. One passing remark about this one, because most of the coronary abnormalities which we saw during that phase, that particular phase, were very quick to disappear, very quick. Perhaps the pathophysiology and the anatomical landmarks were slightly different from this one. You might be able to tell more precisely. So this is the detection and management of coronary thrombosis. One of the main confusions which happens is that often we see thrombus inside the dilated segments. Now whether it is really a thrombus or whether it is something else, because the management would be totally different. In the first frame, you see there is a coronary artery aneurysm involving the LMCA, part of the LAD and the distal LAD, and obviously the circumference also appears to be slightly bigger. In the second frame, you see this was taken on day 2. There was a large thrombus sitting there. It was very difficult to believe. This was a 1.5 months old baby who has been diagnosed with Kawasaki, and we saw this on the day 2. And definitely we gave her the management, and the clot also disappeared. But sometimes it might be, as Dr. Debabrata was telling, it might be pericardial folds overlapping in such a way as if mimicking the coronary. But at the same time, it is difficult not to treat this child, because otherwise it might be playing with life. Giant aneurysm with clot inside. This is the child which I was telling in question. He underwent a CABG, and this is, I just thought I would include the coronary angiograms of that particular child. This is a aortic root angiogram where you can see that the right coronary artery is totally seen, but the left coronary artery is not seen at all because it is totally occluded, and it was being supplied retrogradely by the collaterals. In fact, we planned an OCT for this child, but it was impossible because the probe could not be inserted into the left main coronary artery. These are the distal aneurysms. This was a child, he's an engineer now. He came to, this is a long time back. This angiogram was done by Dr. Vikas Kohli in Arctics. And this was the distal aneurysm, and it was difficult to see on echocardiogram. You can see the proximal coronaries are completely normal. And it was the distal aneurysm which was extremely deep, and it was not seen on the coronary echocardiogram. So this comes to the end of my talk. So believe nothing, no matter where you read it or who has said it, not even I have said it, unless it agrees with your own reason and your own common sense. This is a picture from our city, the city where we come from. Thank you.
Okay, thank you, Dr. Amitabh. So,
thank you, sir.
Three very experienced pediatric cardiologists in the hall today. It's not often that this hall has such eminent cardiologists, so Dr. Sadi Philip, Dr. Amitabh, and Dr. Debabrata. So, do you have any comments on the presentations that you just made. Saji first.
Yeah, I think you can hear my voice. Definitely echocardiography is operatively recovery. But for pediatric cardiologists, I don't think much limitation for echocardiography except the peripheral the areas and circumflex arteries may not visible. But of course, the echocardiography can identify many associated findings like early valvular regurgitation, like AR, MR, and flaggy chordae that indicates that chordal rupture. Whereas lobular LV, if you are seeing with MR, definitely led to the LV dysfunction. And the papillary muscle rupture definitely is due to coronary artery disease. Whereas chordal rupture definitely it is in acute phase due to the immune complex definitely attacking the chordae. Because chordae consists of collagen and the fibrous component, elastin. So this is really interesting that as Dr. Sudhir Singh said, it's definitely described as pancarditis. We are seeing pericardial involvement, myocardium, but whereas endocardium is not much observed in our experiences. Whereas valve and chordae is involved because of that, because the elastin and collagen is much affected for the circulating immune complexes. So ECG definitely will help. That means the initial stage 1, 2, 3 ECG changes in the pericardium. Stage 1 is actually PR level sagging and ST segment is M pattern. So that ECG can identify. So as soon as child is admitted in the ward and suspected at AD, you have to take an ECG because many cases refer to us without ECG they are coming. So ECG will give at least we can identify the pericarditis. So the involvement of the valve and the pericardial lesion and the LV dysfunction definitely we can correlate with the like 2 criteria plus coronary involvement previously we say we can put it as incomplete 3/5 like that. But whereas even though coronary is not involved, vasculitis and pericardial efficiency if you are seeing, definitely you have to consider as a KD and start treatment. Thank you.
Thank you. I think for some amongst the audience they may not know, Dr. Saji has almost 3 decades of experience managing these patients, and he's the founder of the Kawasaki Disease Foundation of India. So he's a person who was primarily responsible for organizing the biennial Kawasaki disease summits in India, and it were these summits which ultimately took the shape of annual Kawasaki disease conferences. So please.
I have a question for sir. Myocarditis is very common in kidney, and most of the patient has myocardial presentation. We don't treat with other treatment. I would not intensify your treatment as such for myocarditis, but any guideline for pericarditis if it is coming this year, we will identify precise ideas.
Most of the pericarditis will subside its own like a natural course. Whereas myocarditis involved definitely I will correlate with the NPRO-BNP and PRO-BNP. In our situation, lab parameters may change. Because of that, I used to repeat once again NPRO-BNP next day. Whenever you see a rising kind of NPRO-BNP, definitely age is concerning. The normal values in the neonatal age is very high, 3,000. It's normal. Whereas 3 to 5 years, above 350 microgram is significant. So, correlating with the NPRO-BNP, you consider as myocarditis. Then EF is low, definitely I will address for IVIG. If the EF is maintained, then neither prednisone I used to advise in the general cases. Kawasaki disease anyway, definitely we are adding up this myocarditis plus other two criteria. Definitely we are starting on IVIG. And pericarditis, usually you won't do anything. Natural way of suspicion is there. IVIG and anti-inflammatory treatment is there now.
Yeah.
So now, you know something about myocarditis. I will ask your opinion. You have a case of sometimes very confused about that really coming to shock. Usually incompletely high current markers land up in the PICU. Majority of the accidents start seeing a shock. So, what is the really a clinical pointers that they say that involve the septic shock in the areas?
Well, our experience is equally sad because once the baby enters the PICU, they hold the reins and they hold their reins very tightly. So you have to convince them that if the child is not improving in spite of antimicrobials and if the blood cultures are repeatedly coming sterile, you have to rethink. And it's all these subtle signs of KD in such a situation. The suggestion of redness of the lips or of the tongue, look at the BCG scar, look for the dilatation of the gallbladder, look for the overall clinical presentation, extreme irritability. It will be these very soft signs which sometimes tilt the balance. But intensivists being intensivists, it's not easy convincing them. So our senior residents, they have had their fair share of fights with their senior residents. But sometimes they agree, yes, and if it is KD shock syndrome, the response to intravenous immunoglobulin is dramatic. It's completely dramatic. It's a different child that you see the next day. So this is maybe one of the senior residents can chip in. Arjun?
The clues that I would say that in higher carditis associated shock, fever is almost on the fever is not that prominent, but in KD shock fever will be prominent. So this is one feature. In overall clinical picture as I told you, and other the echocardiography, bedside echocardiography that we do. And the pro-BNP sometimes gets internal pro-BNP as a biomarker of which is not that elevated in septic shock, but in KD myocarditis is a elevated shock, it may help.
In 2018, we had Dr. Najib Dada delivering an oration on KD shock syndrome, and we had the entire PICU team here in this hall. He tried convincing them, they went unconvinced. So they are a very resistant lot, very resistant lot. Okay, Dr. Devdutt.
Extraordinarily high levels of anti-pro-BNP in these children and high
The question is, were you able to convince your ICU colleagues? That is a question. Yeah, so breathe.
So you told that ProBNP is very high. So that if you tell that ProBNP is a marker of Kawasaki disease to the ICU people, they will not agree. They will tell it is due to the ADI, it is due to shock and.
But actually, we have done a study actually,
One study from here also that the cutoff of NT-proBNP.
So we saw NT-proBNP in KD patients as well as in patients with other febrile illnesses, including patients in PICU with shock or sepsis. So some of the patients with shock and sepsis are very high NT-proBNP. But what we found that KD patients are the more uniform and overall the median value was high. So that's what we found. But individually, if you see some of the patients we have very high.
Dr. Amitabh.
After I have a comment to make. In the under the circumstances which you are describing, often the pediatric cardiologist is called upon to act as a judge, and it's extremely because he is in between. It's extremely difficult to convince both the ends that whether it is Kawasaki or not. I will.
I'm a pediatric intensivist for the last 30 years. And my journey started from PGI under Dr. Smith and Dr. Jayashree. I just want to mention here that we are the most malleable ones. Because what I was practicing 20 years back, regular suction, changing the circuits, doing the cathedral change, changing the central lines, we are no longer doing those things. But we are very, very scientific people. Once we have confirmed hard evidence, we are the first one to change ourselves. So maybe I'm looking at intensivist. So during COVID times, we saw many patients. And during that time, we had used steroids and all that. So we are taking ProBNP very, very, we are also presenting a paper. KD is a real threat, and unfortunate part is that patients start sometimes clinically improving. Very high CRP, you think it's an infection, clinical enteric. Patients on 4th, 5th day starts improving. The CRP falls from 300 to 40, you are happy, but the platelets are now more than 10 lakh. Rest everything is fine, no history of definite rash, and just out of instinct and out of seeing so many patients of KD, so let's repeat the echo. And within that 1 week, echo is done on day 1 and then discharge, and within 7 days the echo shows coronary dilatation. So that's a bit challenging and bit scary situation that we may be missing many atypical KDs. And nowadays the children are dying on the grounds playing. So I mean, we are going to get a room of myocardial ischemia. It's a scary disease. And we are very 27, 20 in New York Center in DMC. 27 years old child, I would call him young adult, coming with diffuse coronary artery disease. They say we cannot do stent. So we do not know why there is such a diffuse coronary involvement in such young people. So maybe the child had a history of high-grade fever in the past, which was missed. Still we get children who are given meropenem, vancomycin. Since CRP is rising, they go to polystyrene, polymyxin, but nobody thinks of it. So I think this is a one thing which we should give advertisement in TV like we give for Delhi. That for pediatricians don't know how to diagnose KD. So it's very, very sad situation. We stop all antibiotics, but by the 3rd week the child already has aneurysm. So I think we should go to the field and tell more pediatricians at the peripheries that please don't hike up antibiotics. If all cultures are negative, suspect KD as the primary diagnosis, especially with high CRP and high platelets.
Thank you, ma'am. I'm sorry, I forgot that you were sitting in the audience. My sincere apologies. Professor Puneet Aulak is a very senior colleague. She heads the Department of Pediatrics at the Dayanand Medical College in Ludhiana. So I wish all intensivists were like you, but they aren't. Dr. Amitabh.
Sir, I have a question for you, sir. Sir, like prior to the early intensification of therapy, like those children who had a giant aneurysm or maybe aneurysmal coronary arteries, so what was the incidence that they used to come back to normalcy, or they were just followed up, they maintained that diameter and all these things? Long-term follow-up.
Many of them, yes, continue to have abnormalities.
Okay, did the diameters come down over a longer period of time, like 5 years?
We have to check the records, but in many of them the diameters did not come down. before we started on the very aggressive intensification.
We have data from Japan and Canada on these long-term outcomes of patients who had small aneurysm, moderate and giant aneurysms. So if you take giant aneurysms, one cohort is from this again Toronto. They followed up for I think 10 years, and one they have from Japan from 1996. So if you see the long-term cohorts, 50% of them may go for a regression over a period of time in giant aneurysms. Around 95% to 90% of them moderate also go for a regression. Small aneurysms were never been a concern. They go for a normalization and maybe
we have a similar result. We have a cohort about 30 patients whom we have followed up over a period of 10 years. So most of them, as you said, the giant aneurysms, they remain so. Most of them have been remained so, but till now they have not formed any strictures just after the aneurysms. The medium ones and the smaller ones, mostly they have gone back to their normal.
I think his specific question was, were the regression rates much less when the therapy was not that aggressive?
There is one study published recently from Japanese experience, and they have shown that the children who are treated recently, in recent years, have chances of regressions are higher. So that means that possibly they are using more treatment intensification recently. They have implicated and concluded their study in that. But they have not looked into the specifically that whether they have used, but what they have shown is that when children who were developed in last decade had chances of regressions are higher rather than who had been treated previously. So there is a possibly relation that
this therapy is actually helpful.
Because we are using treatment intensification in last 10-15 years only, or possibly more in last decades only.
Treatment intensification definitely will matter. I remember one abstract from Dr. Devapal regarding that infliximab and the follow-up of the there was so much regression between infliximab and other IAE.
Over there we saw that earlier you get the infliximab actually, that also mattered. So the earlier intensification was done, so that actually mattered in the long run. So initially because we were also a little skeptical and our colleagues were skeptical, so infliximab was sometimes delayed. So now we give more proactively.
I have a question that in KDS, IAE, most of the KDS cases, IAEs are resistant. So such cases, can we think first line itself as the infliximab for KDS?
I think we have been using more of steroids in such a situation. But infliximab also we have given, but I don't have the exact data. I don't think we have analyzed that data yet. But usually you would give something more than IVA. So I think now it's time to move on to the last session of the day. And this is to be given by Professor Suda. And this is on assessment of cardiovascular risk in children with KD. So this is a very, very important topic because on the bedside, sometimes you often have to take decisions on therapy, especially escalation of therapy based on your own assessment as to the risk factors involved in a given child. So Dr. Suda.
Thank you. Mr. Chairman, and ladies and gentlemen, I appreciate the opportunity to speak on the subject at this session. First talk is principal symptom. The presentation of acute KD varies significantly referred to atypical KD and incomplete KD. Further, it seems this vasculitis manifests differently depending on patient age. Patients less than 3 months of age tend to have few symptoms. On the hand, severe myocarditis predominant in patients more than 4 years old. Abdominal pain and arthralgia often occur in school-aged patients. Acute febrile disease in children which induce sequelae is rare commonly when paired than KD. Mumps, measles, and rubella are good outcome except special cases. However, KD can induce coronary aneurysm due to acute coronary vasculitis. And coronary aneurysms are cause of myocardial involvement relating to this. If coronary aneurysm didn't occur, KD would not be such threatening disease. Therefore, it's most important to diagnose acute KD-induced aneurysm. However, it is very difficult in some cases. As you know, I will describe the clinical characteristic in acute KD, its complication. And in a second talk, I will consider specific coronary abnormality due to KD vasculitis. Acute KD vasculitis has 4 distinct clinical characteristics compared with other acute febrile disease. First, it is a self-limiting disease for 2 weeks. Second, in some cases, recrudescent fever, relapse occurs. Third, widespread symptoms in the whole body. Their diffuse nature may lead physician to an incorrect diagnosis. Fourth is a cardiac involvement, including coronary artery aneurysms. This slide shows the 6 principal symptoms in Japanese guideline. The appearance time of each symptom is not the same, and patients don't exhibit all 6 symptoms. Especially, for example, the only 76% develop cervical lymphadenopathy. Severity assessment in the acute phase include initial assessment of severity of symptoms and then coronary sequelae 1 month after the onset. Assessment related to the prognosis of coronary arteries is the most important from a long-term perspective. In most of patients, lymphadenopathy is unilateral, and then neck movement is severely limited because of swelling and pain. In patients over 6 years old, this symptom often misleads the diagnosis of KD, encouraging coronary aneurysm development because of delayed treatment. Acute KD should be considered in the differential diagnosis of lymph node adenopathy. Erythema is shown. Bilateral conjunctival congestion is very important. In Japan, redness in BCD site is an important finding. About 20 of KD patients have persistent or recurrent fever more than 36 hours after the end of initial IVIG infusion. There are delay of the diagnosis of incomplete KD. Further, there are 3 factors which mislead the diagnosis of KD. One is incomplete KD and diffuse symptoms throughout the whole body rather than principal symptoms. The second is the infection occurring either at age less than 3 months or more than 6 years. The diagnosis of KD in this age likely to be delayed, which leads coronary aneurysmal formation. The percentage of incomplete cases has increased since 1990s. Systemic convulsion and facial nerve palsy may reflect neurological involvement. Erythema and induration at BCG site is well recognized as a characteristic symptom of KD. Abdominal pain is frequent in patients of school age. These symptoms, rather than principal symptoms, often obscure the correct diagnosis of KD. Acute KD is generalized medial-sized vasculitis. Therefore, it's important to detect varied symptoms in the whole body. Vascular hypermeability caused by hypercytokinemia induced water and protein leakage with albumin in the plasma. As a result, hyperalbuminemia and hyponatremia may complicate the acute phase of KD. There are some characteristic laboratory findings which help the diagnosis of KD. In the acute phase, hyponatremia is very important finding. Hyponatremia indicated hypercytokinemia. If AST is increased with hyponatremia, KD should be strongly suspected. Standard therapy for acute KD involves high-dose intravenous immunoglobulin, with aspirin should be administered initially. However, 1/5 of initial IVIG have persistent recurrent fever, and additional IVIG is needed for them. Some patients require further adjunct therapy. Resistant cases may receive corticosteroids, cyclosporin, TNF-alpha blocker, plasmapheresis are considered. However, there is no current therapy guaranteed to be effective, and above drugs are used in combination. In the last of refractory KD, additional IVIG are often used after each adjunct therapy. The goal is alleviation of fever within 11 illness days. The scoring system in the acute phase is widely used in Japan and relied on to predict possibility of treatment resistance and results that affect coronary prognosis associated with the severity of symptoms. There is no current therapy guaranteed to be effective for IVIG-resistant KD. We report a successful early aggressive combination treatment for one IVIG-resistant case. A 2-year, 6-month-old boy with 5 principal symptoms was transferred to our hospital on the 3rd day of the illness. On admission, IVIG 1 gram per kilogram per day for 3 days was slowly administered intravenously. Cyclosporin was started. After infliximab was administered for 2 hours intravenously, his fever alleviated and his condition improved. The findings of his blood test are shown. Hyponatremia, AST is increased. The scoring in the scoring system, Kobayashi, Gunma, and Kurume, Egami, and Sano Osaka score, which predicted an IVIG resistance, was 8, 5, and 3, respectively. He was suspected to be an IVIG resistance case. Steroid is used as primary therapy for patients who are judged to be at high risk score for CAA when their first presentation. However, these therapies are not always perfect. If the coronary artery are dilating, steroids should be avoided. Cyclosporin therapy is also used additional therapy, and its effect can be judged within 2 days. Plasma exchange with 5% albumin is performed at limited number of institutions. The mean duration is 3 days, and the maximum is 5 days. Prompt diagnosis and treatment is crucial to prevent coronary aneurysm. The diagnosis and the treatment should be performed in the optimal time. In patients with unknown fever, two-dimensional echocardiography is an important modality. We think IVIG therapy is not too late, not too early. The optimal type, which we believe is 5 to 6 days after the onset of KD. For IVIG-resistant patients, combination therapy are needed. Recurrent fever can be caused by CAA. As you know, acute KD involves cardiac regions selectively. Although their prevalence of the following very low, severe cases of endocarditis, myocarditis, and pericarditis are sometimes encountered rather than coronary arteries. Endocarditis leading to mitral regurgitation especially occurred in patients under 6 months. Myocarditis with unconsciousness in the early days of acute phase occur in patients more than 4 years old. Pericarditis is found both acute and late phase. Cardiac tamponade is a rare event. No, sorry, no, not move. He's left in 5 years old boy. His left ejection fraction was decreased. Electrocardiogram showed tachycardia and ST depression of chest lead. Inotropic agent and diuretics were used. Water balance control was required. The left ventricular ejection fraction improved within a week. In the early phase of acute KD, some patients have severe decrease in the left ventricular ejection fraction and tolerate transfusion badly. Acute vasculitis due to Kawasaki disease can cause coronary artery lesion with short and long-term myocardial involvement. We measured the largest diameters of each coronary artery in the initial coronary angiogram within 100 days after acute KD. In this slide, the x-axis plots the maximum diameters in the branch, and the y-axis years after the onset of acute KD. The larger diameter, the shorter the appearance of stenotic lesion. An orange point indicates a stenotic lesion. A brown circle was non-stenotic lesion. The larger diameter, the shorter the appearance of stenotic lesion. This slide indicates the evolution of coronary aneurysm in the late period depends on the diameter of aneurysm in the acute phase. The coronary artery system consists of 3 major branches. If a coronary artery aneurysm occurs in one branch, collateral arteries from the other branch will develop. Consequently, The extent of collateralization is believed to determine the occurrence of cardiac events in patients with coronary artery lesion caused by KD. The outcome in such patients depends on CAA characteristic in acute phase and on stenotic lesion and myocardial involvement in the late phase. However, initial strong determinant of outcome is characteristic of CAA in the acute phase. First, we reviewed the outcome and incidence of cardiac events 214 patients who had undergone an initial coronary angiogram within 100 days of acute onset between 1978 and 2011. We divided the patients into 3 groups determined by maximal CAA diameter as shown in the table. We show some examples. The upper slide case included in the L group, and lower left side case is in M group. The number of patients each group is shown and was large. 98, medium 59, small 37, and very small 20. The next slide shows the gender distribution of the respective group. In total, the number of males is 3 times that of females. This graph shows the laterality of CAA in the respective group. The number of bilateral CAA in L group was significantly higher than in S and VS group. Distribution of CAA in the 4 groups based on the maximum CA diameter. With a larger maximum CA diameter, CA might be expanding from the proximal to the distal portion. This graph shows distribution of CAA in the 4 groups based on maximum CAA diameter. With a larger maximum CAA diameter, CA might be expanding. The distribution of CA caused by KG, the larger maximum diameter of CA exists in more extensive and more bilateral. The degree of the diameter of maximum CAA also can reflect the coronary involvement to the longitudinal direction due to acute vasculitis. This table, the onset of KD, the interval from the onset of KD to latest CAG, and the follow-up period. The follow-up period in S group was significantly shorter than L group because the clinical course is uncomplicated in the S group. The follow-up in most of these patients was discontinued. The number of patients receiving anti-thrombotic therapy in the late phase is shown in this slide. The ratio of warfarin in the L group was high. Cardiac events occurred in 44 patients, as shown here by groups. About half of episodes related to MI. Some means of coronary artery revascularization was CABG was undertaken in about 70%. 30-year survival rate in respective group is shown. It was 93% in the large group. The 30-year cardiac events-free rate in the L and M group were 59% and 88% respectively. Further, we classified between either bilateral group and unilateral group, adapting the laterality of maximum CAA to decide respective group. For example, the left side case included the bilateral L group, and the right side case in the unilateral M medium group. We see the example cases. The upper slide included medium bilateral groups, and the lower slide is included medium unilateral group. Next, the 25-year cardiac event-free rate in respective groups based on the diameter and the laterality of the maximum aneurysm is shown. The lowest group was large bilateral group. In summary, about cardiac events, it can occur in medium and large groups. Further, the incidence of CE in patients with bilateral CAA is significantly higher than that in patients with unilateral CAA. On the other hand, diameter of CAA can relate to BSA. 30-year cardiac event-free rate in M and L group based on BSA are shown. Cardiac event was not found in M group in BSA more than or equal to 0.5. The 25-year cardiac event-free rate respective group based on BSA, the diameter and laterality of maximum CAA are shown in this slide. The value of 25-year C-free rate in respective group in the table. C-free rate was low in L and bilateral M group, less than 0.5. Risk rank based on the three factors are shown in this slide. Severity assessment of KD in JCS guideline was shown. In summary, the fate of CAA depends on its diameter, and diameter more than or equal to 6.0 mm can lead to stenotic lesion. Cardiac events in patients with coronary artery lesions caused by KD can occur. In the case with the maximum diameter more than or equal to 6 mm, when BSA is less than 0.5, and the maximum CA diameter equal to over 8.0 mm when BSA is equal to over 0.5 in the acute phase. CA by KD vasculitis changes its morphology years and years. Its change greatly depends on the degree of involvement of coronary artery wall due to acute KD vasculitis. The degree of diameter of CA reflects on degree of involved coronary artery wall. Therefore, maximum diameter of largest CA predicts the outcome of its coronary artery. It's very important to know how large in CAA in the acute phase. Thank you for attention.
Thank you, Dr. Suda. So, only Dr. Suda can present such data. 25 years follow-up, 30 years follow-up. Very few centers, very few countries in the world will have this kind of data. Again, re-emphasizing the fact that the cohorts of KD at various centers in our country, fortunately there are many, many centers that have now accumulated large numbers of patients. So we have to keep on following them for years together, and that is how we will get useful information. The essence of Dr. Suda's presentation is that we must do everything that is in our armamentarium to prevent the development of large aneurysms. So thereby again emphasizing the fact that you have to prioritize treatment in patients with AD who require very aggressive forms of therapy. So that is infants, especially babies below 6 months, male infants especially, or very older children, again in whom you will have more severe disease, children with KD shock syndrome, children with macrophage activation syndrome. These are the situations where we really have to be very, very aggressive. Also, what has emerged from her talk is that children who have more aneurysms, bilateral involvement, left side, right side, they will have more complications. So these are some very, very important messages that have come out from her talk. The disease severity systems which are being followed in Japan, the Sano, Igami, Kobayashi, different centers according to her, follow different systems. These have not been truly validated in other countries. But what has been validated is subsets of AD that require preemptive aggressive therapy. So those subsets we have already discussed and already deliberated upon. So if there are questions, we still have a few minutes. Yeah.
What was the youngest age at which a CBT was done?
1 year. 1 year old.
We had it in India.
CABG for children with KD. CABG in children with KD. 2 have been done in Kochi?
Yeah, but that age I'm not sure, sir. But from the 4 years only, as far as
I think the first 2 CABGs which were done in India, 4 or 5 years, not younger than that. Very few CABGs have been done. I know that one of these, the patient did not survive, the other has done well. We haven't done any here in PGA. Delhi, they have a couple of patients. Calcutta, CABGs, 3. And they have done well. So not too many have been done in our country.
I was in UK in 2009 for my fellowship and I was interested in echo, so I was with Dr. Ladies, who is one of the best pediatric cardiologists, and he used to see lots of patients with aneurysm actually in his OPD. And he used to say 8-9 months like this is the result test we can't do. So I don't know whether less than 1 year anybody else in the world is doing. Nothing was done for those children. Those children were left to they would ultimately die. That was sad state, large aneurysms.
In our experience, whatever we have learned, that if you give anticoagulation, if you give aspirin, these children do reasonably well. They grow, they carry out their activities of daily living. But yes, that risk of sudden death, that risk of thrombosis remains. But with more refined anticoagulation, so far we have not had much progress. But these children who have such complicated coronary artery anatomies, they would land up in difficulty when they grow up to be young adults. So the question again arises, who will deal with them? Because most cardiothoracic surgeons may not have the requisite experience of dealing with them. Any other question?
Thank you, ma'am, for this seminar. So, what are the agents that you use for primary investigation? What are the agents that you use for primary investigation?
In addition to intravenous immunoglobulin, Suppose a child needs intensification. Do you use second dose of IVIG, infliximab, cyclosporin?
Yeah, in our institution, in second cyclosporin, and TNA alpha blocker. In our institution, no steroid. But in our institution, in most of patients in coronary artery lesion, in late period, in acute patient, small, number of small.
I think we thank Dr. Suda for her marathon sessions. She gave 3 talks today.
Thank you very much.
We thank the audience. It's 6:30 in the evening, and to have so many interested people from diverse backgrounds discussing these patients, I think it's very, very encouraging. Tomorrow we would begin at 8. So I request everyone to be here by maybe 5 to 8, because tomorrow we have the youngsters presenting their cases and they would need all the encouragement. So 8 o'clock. So it's the resident doctors who would be presenting cases, so I would request everyone to encourage them, and we must be here by 8 o'clock. Thank you.
Usually